ID is RMNC catch 0091.
Yes, we heard you. Can you hear us now?
Yes, madam.
Okay. Catch ID 0107, Dr. Shweta.
Yes, ma'am. 0151.
No. Dr. Shweta P, are you here? Third participant, catch ID 0119, Dr. Syed Iqtidar Ahmed. Are you here? Catch ID 01. Are you here? Preeti Ashok, ma'am, if you're here, please say yes. Catch 0151, Dr. Shweta Kurkuri.
Yes, ma'am. Present, ma'am. Hello.
Catch ID 0164, Dr. Christy. Dr. Preeti Ashok, can you please mute yourself? Catch ID 2107, Dr. Shweta P. Are you here? Dr. Shweta P, if you can hear us, can you please say yes, ma'am?
Hello, good morning, everyone.
Good morning, sir.
Good morning, sir.
Good morning,
Good
sir.
morning, everyone.
We will start the session shortly, sir.
Sure.
This is waiting for
Good afternoon, everyone. Welcome to the 32nd State Level Annual Conference of Karnataka Association of Community Health, hosted by Ramaya Medical College. The theme this year is Redefining Public Health, COVID-19 and Beyond. With this, we shall begin our session, a poster presentation for PGs. Let us take this opportunity to introduce our esteemed judges for the day. Dr. Sangameshwar Sir, Director of Public Health, Consultant for the Southeast Asia, UAE, IQVIA, and Africa. And Dr. Venkatesh, Professor and Head of the Department of Community Medicine, Hassan Institute of Medical Sciences, Hassan. We are very thankful to you for dedicating your precious time to judge our session today, sir. Today's session will be moderated by myself, Aparna.
And I'm Neeti. We are both UG students of Ramaya Medical College, third year.
Let's go through the instructions for the day. This is participants, please pay attention.
Yeah.
The most important instruction for the day is please stick to your time. We have 5 minutes for your presentation and 2 minutes for questioning by the judges. We will intimate you before 1 minute, 1 minute before your session ends. That is after 4 minutes of your time passes. With this, let's start the session for the day.
The first participant for the day is Dr. Palli Satya Reddy. Sir, are you ready?
Yes, madam. That PPT.
We shall share the PPT. Or do you want to share the PPT?
Yes, madam. Just I have made some little bit corrections. Here, how I have to share in this?
I think it'll be better if we can share it, sir. 1 minute.
Yeah. You can. You do that.
Is this visible to you?
No. Just still more zooming is needed, madam.
Is this okay?
Yes, madam. Yes.
This is fine, sir? Okay.
Yes,
Yeah.
madam.
So I think we can scroll across the screen as and when necessary because this is in a portrait format. So I suggest you zoom it up a bit more so that the speaker is comfortable.
Yes, sir, definitely. When the speaker intimates us, we shall conclude accordingly.
Yeah. Yes, madam.
Yes, sir, you may start now.
Okay, madam. Good morning, sir. Good morning, everyone. Myself, I am Dr. Satya Reddy, postgraduate from Navodaya Medical Department of Community Medicine, Navodaya Medical College, Raichur. Today I am going to present you on a topic of poster presentation on a cross-section study. Yes, madam. Just a cross-section study on assessment on knowledge on HIV/AIDS among students of a nursing college. Introduction. HIV continue to be a major global public health issue, having claimed more than 32 million lives so far. However, with increased access to effective prevention, diagnosis, treatment, and care, including for opportunistic infection, HIV infection has become a manageable chronic health condition, enabling people live with HIV to lead long and healthy lives. My aim of the study is aims and objective of the study is to assess the awareness of HIV/AIDS and its association with demographic characteristics among nursing students. Methods and methodology. What I have used is a study design is cross-sectional study. Study participants are all 160 students of nursing college, out of which 84 students were from second year, 54 students were from third year, and 24 students were from fourth year of nursing college at a private nursing college in Raichur. Exclusion criteria is all first year nursing students I have excluded from the study. Study period is from 1st November 2019 to 31st January 2020. For the duration of study is 3 months. And sample size is all students of nursing college, excluding first year. Data was collected using a pre-designed questionnaire. After taking a informed consent, a qualitative data was analyzed using chi-square test. EpiInfo version 7 was used for analysis. A p-value of 0.05 less than 0.05 was considered as statistical significance. Madam, can you scroll up? Results what I have got is like out of 162 students, majority of 107 students, nursing students have good knowledge on HIV/AIDS, followed by 41 students of nursing students have excellent knowledge, and 14 nursing students have poor knowledge. Association was found among students age and studying year and their parents occupation of nursing students, and students who have participated in HIV/AIDS facilitators workshop to overall knowledge on HIV/AIDS were shown statistical significance, that is p-value less than 0.05. And just madam, little bit of just scroll down. Socio-demographic features are like age. Majority of the students were less than 20 or equal to 20 years, and majority of the students were from religion Hindu, and females. Majority of the students were female, and their parents' occupation were agriculture. Have shown majority. Majority of the students were like second year students. Participation in trainers workshop are like many have not participated in the trainers workshop, and in facilitator workshop majority have
Now you have 1 minute left. Please keep that in mind.
yes madam, and here in my pie diagram, hello. Yeah.
We can hear
In
you.
my pie
Continue, Satya.
Yes. Yes, sir. In my pie diagram, I have got like results. Majority of the students were like have good knowledge of 66.05% on HIV, having HIV knowledge, and excellent have shown like 25% of students have excellent knowledge. Madam, just can you? And association among nursing students on overall knowledge on HIV has shown statistical significance with age less than 20 or equivalent to 20 years, and occupation, their parents' occupation with agriculture, overall occupation, it has shown significance, and years of study also it has shown significance. Madam, very good. And facilitators workshop. It has
Sir,
shown
I need to
statistical.
intimate you that your time is up, sir.
Your time is up.
Yes, yes, yes. Just one.
So we shall stop sharing the screen now.
Okay.
Judges, you have 2 minutes to ask questions to the participant.
Dr. Venkatesh, perhaps you can go first, please.
Hello, sir.
All right.
Hello.
So, Satya,
Sir.
yes, Dr. Venkatesh.
Go ahead, sir. Go ahead, sir. Second.
Hello. Hello, sir.
Hello.
Yes, sir.
Yeah,
Audible.
ready. Yes,
Yes,
audible.
sir.
So, why did you select this group, Satya?
Sir, actually means I want to assess knowledge on only nursing college students, excluding first year group, sir, because first year students would not have participated in any training or training workshops.
Okay. Considering the students from nursing background,
Yes, sir.
what specific question you have asked to understand their requirement to reduce HIV infection?
Sir, voice cutting.
No, they are from nursing background, right?
Yes, sir.
So, what is the specific question that you have asked so that they need to be informed to reduce the chances of transmission?
No, sir, if they have good awareness on the disease spread and whatever regarding HIV patients handling, because they are the front line who used to handle HIV cases during treatment or and follow-up of HIV cases.
Yes, correct. But any specific question which would reduce transmission among the students?
No, sir, it's like assessment only. No, sir, their knowledge, whether they have knowledge on this ongoing pandemic.
Okay, so you have not included question on transmission with needle stick injuries.
Yes, sir. Yes, sir. That I have not included, sir. Regarding transmission related.
Oh, right. What are your conclusions?
Sir, conclusion is like mine. Sir, it's like the students who have participated in the study, the nursing students who have participated in the workshop had better knowledge when compared with the students who have not undergone any awareness training on HIV.
Okay, what workshop were you interested with?
Sir, any means here the facilitators workshop, facilitators workshop or training workshop.
Had you known this before you started this study?
Yes, sir. I have asked their faculty members also regarding this, whether they have undergone any workshop related things within the college.
Right.
Judges, sir, I would have to intimate you that the time for questioning this participant is up and we have to move to the next participant. Is that okay?
Okay, yeah.
Yeah,
So over to you, sir.
I just have one question here. We have 1.5 hours, which is 90 minutes, and we have 7 participants who are presenting, right?
Yes, sir. Go ahead.
Yes, sir, sure, sir. Go ahead. Just
So
wanted to ask.
I think let's have some buffer. Let's have some sub buffer. I suggest we should have buffer because there are some important questions which Dr. Venkatesh is asking. So I guess 5 minutes I think is an important time for the presenters, but I think the judges should also get some time to understand, probe a little more for the presenters.
Yes, sir.
Yes, sir. Sangameshwar, sir. I'm done. You can go ahead.
Dr. Satya, I think this is a very interesting study. I just also wanted to understand, especially again coming back to the conclusions and carrying from where Dr. Venkatesh left, right?
Yes,
What your research? Because a lot of that question beyond questions you have asked, the type of tools you have used. And essentially, that's the questionnaire that you have used. Do you think a one assessment would be enough to really come to a conclusion on their knowledge levels and especially might have implications?
Yes, sir. It's like means whatever the if they participate in a number of workshops, no, sir, they will get updated to the content of whatever is going on. That's my point of view, sir. Whatever it's like facilitator workshop or it's like trainers workshop, no? They will get updated to the content, no, sir. Ongoing updates they come to know. That is my point of view.
And how frequently are these workshops conducted? How frequently are these trainings?
Sir, in this nursing college, what I came to know is
That would be an important aspect.
yes, sir. Every quarterly we can quarterly we can conduct our even 6 months, every 6 months. At least in per annum, two are needed, sir. Two are needed. Two workshops are needed, sir.
Okay. Very well. Thank you, Dr. Satya. Good luck. And I suggest you continue doing this, and perhaps it might be a good idea to do a pre-workshop evaluation and a post-workshop evaluation. I think that might be a better idea. And especially if you have a longitudinal design to your study, that might probably help you track the knowledge levels that are changing over a period of time. Over.
Yes, sir. Thank you, sir. Thank you very much. Thank you, Venkatesh, sir.
I guess we are done with the first participant. If Dr. Venkatesh does not have any further questions.
We are done, sir.
Very well. So maybe we call the second presenter, please.
Yes. 137.
Dr. Preeti Ashok, are you here? Ma'am?
Just one question. We have a particular list of participants which is going in an ascending order of their registration ID. Next participant was supposed to be Dr. Shweta P, who's going to
Sir,
present
she's
some.
going towards the end. Has some technical difficulties. She got in touch with us. Is that okay?
No, that's fine. That's fine. Because for our scoring, we just want to make sure that we are not following any particular order. So we'll be extra careful when we are awarding the marks. We'll just make sure the IDs are matching. Please go ahead.
Still waiting for someone to join, so we will do it.
Ma'am, we are unable to hear you. Can you please unmute yourself?
Were you talking to me? Sorry, I was on mute.
No, sir, we were talking. Dr. Preeti Ashok, ma'am.
Which is fine. I think we just have to be a little careful, Dr. Venkatesh, when we are awarding because they're not following any particular order here.
Dr. Preeti Ashok.
No, we're not able to hear you.
ಇದು ಕನೆಕ್ಟ್ ಟು ಆಡಿಯೋ ಅಂತ ಐತೆ ಬಟ್ ಏನ್ ಕನೆಕ್ಟ್ ಆಗ್ತಿಲ್ಲ ಆಡಿಯೋ
ಈಗ ಏನ್ ಮಾಡ್ಬೇಕು ಹೇಳಿಲ್ಲ ನೀನೇನು
Mention connecting to.
Shweta, we are able to see you.
Respond. Yes, sir.
We are able to see you. What's the problem?
Yes, sir.
The coordinators, I think you need to coordinate and say what you want to us. I think just connected and choose on.
No, without this. Order again. Is that okay? Hello, sir.
Yes, yes, Shweta, you are audible. Yeah.
We can hear you, Dr. Shweta.
Yes, sir.
Sharing your presentation now.
Next. Shweta?
Yes, sir. So can you hear me?
We can. Yes, please.
Okay. So shall I start?
Yes, Shweta, go ahead. Go ahead.
Yes, sir. Good morning, sir. I'll be presenting. I'm Dr. Shweta from BIMS. I'll be presenting my poster titled Cross-Sectional Study on a cross-sectional study on overweight and obesity among adults in urban field practice area of Department of Community Medicine, BIMS, Belagavi. And introduction, obesity is the most prevalent form of malnutrition in developing and developed countries. It acts as a risk factor for other non-communicable diseases. Increase in intra-abdominal obesity has more risk for cardiovascular disease. The objective of my study were to estimate the prevalence of overweight and obesity among adults in urban field practice area of Department of Community Medicine, BIMS, Belagavi. The methodology involves, it was a cross-section study involving 498 subjects, and the study populations were adults above 18 years of age, and it was done in urban field practice area of Department of Community Medicine. The tools used were structured questionnaire, weighing machine, measuring tape, and the method of data collection involved interview method, and the sampling technique was systematic random sampling. Coming to the results, figure 1 titled The Distribution of Subjects According to BMI. It shows 8% of the populations were underweight, and 53.1% were having normal BMI, and 24.4% were having overweight that is more than BMI of 25, and obese were 14.4%. And coming to the table number 1, which is titled Distribution of Subjects According to Social Demographic Profile. 192 patients were in the age group of 18 to 39 years, and 150 were in the age group of 40 to 59 years of age, and 156 were above 60 years of age, and 236 were males and 262 were females. And coming to the marital status, 74 were married, 392 were unmarried, 90 were widowed, and 2 were divorcee. And coming to the religion, majority were Hindus, around 412. And coming to the table number 2, which is titled Distribution of Subjects According to Waist Circumference, 2.4% of males were having their waist circumference more than 102 centimeter, and 21.6% females were having a waist circumference less than 88 centimeter. Sorry, that was more than 88 centimeter. And coming to the table number 3, which is titled Distribution of Subjects According to Waist Hip Ratio, 1.2% of the males were having their waist hip ratio above more than 0.95, which indicates central obesity, and 41.7% of the females were having their waist ratio more than 0.85, which again indicates the central obesity. And coming to the strengths and limitation of the study, majority of the population were aware about physical activity, and the sample size is too less to generalize the prevalence. And coming to the conclusion, the study shows high burden of overweight and obesity among the study population. Recommendations were there is a need for promoting healthy lifestyle in control of obesity, and references were the Park textbook of preventive and social medicine, and Suryakanta H community medicine with recent advances. Acknowledgement, author extends sincere thanks to all the participants for cooperating during the study.
Sangamesh, sir, go ahead, sir.
Well, thank you, Dr. Shweta.
Yes, sir.
I have a very basic question. I mean, you have done a good study. I think a lot of this is pretty self-explanatory and definitely meets all the criteria that we were looking for. But I think as of rigor or the depth to which you have gone is simply, what I'm trying to ask here is, could the study have been done by somebody?
Sir? Sir,
Is
I'm
there
not
any
Sir, I'm not able to hear.
is
Dr. Sangamesh.
Hello?
No, your voice
Yes,
is
sir.
breaking.
Yes, sir. Yeah. Yes, sir. Yeah. Actually, it is getting cut, sir. Like it is not.
posts if you have or is it only me talking to me?
Sir,
Hello?
hello, sir, your voice was not clear. So, can I interact with her, sir? Hello, Pooja, let me ask a few questions to you. Am I audible?
Yes, sir. Your voice is audible.
Okay, so what was, so you said you have done your study in a urban field practice area, is that it?
Yes. Yes, sir.
What is the population of this area?
It was around 59,000, sir.
59,000. So how did you arrive at 498 studies?
Sir, I've taken the houses, sir, number of houses in, it is divided into several areas. And from that, I've taken houses and divided by my sample size to get a sample interval. And then I've added that sampling interval to each, first number is taken randomly, then again the consecutive houses are taken by adding the sampling intervals.
Okay. So could you meet both male and female members in the household?
No, so like during my time, like when I went, majority were females, and most of the males were at work.
So you could have mentioned that in your limitation.
Okay.
Sir, I think you'll be audible now, sir.
Yeah. Yes, please. I thank you. Thank you so much, Dr. Venkatesh. I think the point that Dr. Venkatesh mentioned was about the limitations. I think the kind of research, to be honest, Dr. Shweta, that you have done could easily be done by an undergraduate or perhaps even an high school student. My point is, it would have been better if you had combined these risk factors by also assessing any other comorbidities or morbidities in the context. So I think that would be my suggestion. It's a comment, but I think this research probably is too superficial in my honest view. Okay. And also, more importantly, you should have highlighted this because this looks to be a single cross-sectional study, as you rightly said, without probably clear implications on how the findings of this research would be are you going to take any actions? Are you is this going to inform any particular interventions that are currently happening in your field practice in Belgavi?
So this was done like as a part of our thesis, sir.
Okay, all right. No further questions.
Thank you.
Thank you.
Thank you, sir. So we shall move on to the next presentation.
Yes, sir. Next participant, tax ID.
Are you ready?
I think we can go on to the next presenter.
Dr. Syed, sir, you're not audible right now. Dr. Syed, sir, are you ready? Can we start with your presentation?
Sir, you are not audible.
We can hear you, Doctor.
No, I am not able to hear you. Sir, unmute yourself. I'm not able to hear Sir. Facilitators?
Dr. Syed, sir, we are not able to hear you. Are we audible to you?
Can you hear us, Dr. Syed? No, I think just check if it is plugged in properly. Please check if it's plugged in properly. No, sorry. Dr. Syed, if you don't have any background noise, then why don't you remove the earphones and speak directly through the laptop's microphone?
Dr.
No,
Syed, sir, we
sorry.
are still unable to hear you. Can you hear us?
Dr. Syed, why don't you check your system and try to join in with another system while we can continue with the other participants in the interest of time? Facilitators, could you let Dr. Syed know that he can try with another system and we can move on to the other participant?
I know, sir. Not losing. Are you ready?
Yes, I think we should move to the next presentation.
Okay. Dr. P. is here, but she's not available. So we shall move on to the next participant. Saturday is here. Dr. Kokuri. Are you ready?
Yes, ma'am.
Okay, we shall start.
Shall I start, ma'am?
Start.
Good morning, judges, teachers, and my dear friends. The title of our study is Vitamin A Supplementation Coverage and Factors Determining It among Migrant Workers' Children 12 to 36 months in urban Bangalore East. So, as we all know, vitamin A is one of the essential micronutrients. Under 5 children are the ones who are going to suffer from its deficiency. But children of migrant workers, they are more vulnerable to its deficiency because of frequent shift of places, poor knowledge among the parents, and low socioeconomic status. So with this background, the objectives of the study were to assess the vitamin A supplementation coverage among migrant workers children aged 12 to 36 months and to identify the reasons for partial and non-coverage and factors determining it. This study was a community-based cross-sectional study which was conducted among 500 migrant workers children aged 12 to 36 months who were residing in migrant areas of urban Bangalore East. So the study was carried out for a period of 5 months. Parents who gave consent to participate in the study and who were residing in the study area and during the study period were included, and children without adult informants were excluded from the study. So, cluster sampling method and PPS sampling method was incorporated in the study. The study was conducted after obtaining Institutional Ethics Committee clearance. This data had pre-tested semi-structured questionnaire. The questionnaire had 2 sections. Section A was for socio-demographic details and Section B had vitamin A coverage details. The data was entered and analyzed using EpiInfo. Chi-square test was applied to look for the association and p-value less than 0.05 was considered statistically significant. Coming to results, the mean age of the study population was 25.23 months. So in figure 1, we can see that vitamin A coverage among children of migrant workers, 33% of them had received all the doses, 51.20% had received at least one dose, and 15.8% had not at all received the dose. Moving on to figure 2, it shows the distribution of children aged 12 to 36 months based on vitamin A supplement administered. So for first dose, 500 children were eligible and of them, 84.2 received the dose and the remaining did not. Out of 379 children who were eligible for the second dose, 44.8% received and 55.2 did not. Out of 308 children eligible for the third dose, 25% received and 75% did not. And out of 253 children who were eligible for fourth dose, none of them received the supplement. The table 1, it shows the relationship between socio-demographic variables and vitamin A coverage. Various socio-demographic variables like age group, birth order, father's education, father's age, mother's age, father's age at marriage, mother's age at marriage, religion, type of family, socio-economic status, and previous place of stay before migrating to Bangalore and duration of stay in Bangalore were the factors which were associated with vitamin A coverage. Of these variables, age group, birth order, father's education, and mother's education were significantly associated with vitamin A coverage. The dropout rate from first to second dose was 46%. From second to third dose, it was 44.2%. And from third dose to fourth dose, it was 100%. The common reasons for the dropout were inconvenient time, unaware of need, and busy schedule of the parents. Migrant workers' children were assessed for vitamin A coverage, and cluster sampling method along with PPS was utilized. So these were the strength of our study. 40.8% of the children did not have immunization card. So the information was gathered from parents by recall method. So recall bias would have been the limitation of the study. To conclude, vitamin A coverage was 33%. The most common reason for the dropout was inconvenient time, and the factors which were determining vitamin A coverage were child's age, birth order, mother's education, and father's education status. Hence, we recommend that efforts must be directed for initiation and complete coverage. Okay, ma'am. The reasons for partial and non-coverage should be addressed. The camps must be organized near the high-risk areas at the time convenient for migrant workers. So these are my few of the references, and we are grateful for the facilities provided by our institution. Thank you.
Dr. Venkatesh, may you go plus?
Yes, sir. Shweta, nice presentation.
Thank you, sir.
How did you try to assess your second object?
The second objective, the reasons for partial and non-coverage were if the child had not taken one of the supplement, the most common reasons, like there were multiple reasons, and the most common reasons were listed out. So there were multiple responses. The maximum of 3 we had included in this study, sir.
Okay, but as I do understand, you have tried to assess the participants' perspective, but
Yes,
the providers, the health system or the providers' perspective. So that assessment was missing.
So I'm sorry, sir, I didn't
The
get
second
it.
objective you have. What is your second objective?
So the second objective was to identify the reasons for partial and non-coverage and factors determining the coverage.
Correct. So coverage is to be done by the provider.
Yes, sir.
So that is missing. Yeah.
Yes.
I see that that component is missing.
Okay,
So
sir.
did you make any inquiries in the PHs or sub-centers in staff who provide the primary service? So that
Yes, sir. Because these migrant workers, they keep shifting their places, so it is difficult to catch them. So the questions were asked directly to the parents for the most reason for the dropout. Why was the child not taken for the supplement, or why was he not given?
so is it because of the literacy or because they didn't have access to it?
It's mainly because of the poor knowledge, sir, and the time that is inconvenient for them to take the child for vaccine, like for supplementation.
I think Dr. Sangamesh should intervene here. And
Yes. Thank you, Dr.
Yes.
Venkatesh. Yeah, Dr. Shweta, I think this is a good study. I think it also does pose some larger questions to the fact of how we deliver our health services. In your study, you said factors that were. I just wanted to understand whether factors that were very unique to migrant workers, because a lot of the risk factors as well as the determinants that you have outlined seem to be true for most of the urban poor, right? Be it in terms of their inability to take time out for seeking health services, or maybe their poor knowledge or awareness has a lot to do with their inability to seek the health coverage, right? So my
Yes.
question is, did you encounter any factors that were very unique to migrant workers? That is part one. And second question was, does your research also highlight any other important issues with the way we deliver our health services? Because a lot of times the fixed post services that we offer, all right, maybe, and also with a lot of outreach initiatives happening, right? So could there be some twists? Maybe we can tweak something of our health services to probably improve the coverage for not only vitamin A, but also many other interventions which are actually necessary at a community level. Over. Sir.
So coming to the part one question, the most common reason which I would like to highlight, apart from the inconvenient time or unaware of need and the parents, busy schedule of the parents, there was the next most important was the migration reason. Because of the frequent shift of migrants, they were unaware to go to which place for vaccination or for the supplementation. So that was the main important reason, apart from the others, migration for the dropouts. And the second point is that so migrant workers, most of the time there will be construction workers, slums, or working in any of the brickland factories. So it is our recommendation that the camp should be organized near the high risk areas at the time which is convenient for the parents or the guardians. So like it can be, so in a week, one day will be off for the migrant workers. So they can, the camps can be conducted on that particular day or might be in the evening. Though it is difficult for the health workers, but we can see that the child receives the supplement.
Could the vitamin A supplementation also be combined with any other initiatives or any other interventions?
Yes, the routine immunization. The first dose and the second dose will anyhow go with the routine immunization. But the third, fourth, and the subsequent doses are missed.
Right. One last question here before I'll pass it on to Dr. Venkatesh is how do you determine the migration criteria or the migrant criteria? I believe there will be different criteria, but how did you kind of zero in on one single common
Yes, sir.
criteria for including all your respondents?
So the migrant for the operational definition, which I included in my study, was the persons who were staying in brick lanes, slums, construction workers who were coming outside the Bangalore and they were staying 1 month prior to the date of interview and up to 6 months.
Okay, Shweta, how many such migrant populations could you give?
So actually, there were 226 migrant areas in urban Bangalore East. So out of which, with the PPS and cluster sampling method, we arrived at 500 migrant areas.
Out of how many?
226 migrant areas were there, sir, in Bangalore East, urban Bangalore East.
Out of 200, how many did you pick up for your study?
So 50 migrant areas, because my sample size was 500, 10 children from each cluster, so 500.
So were you trying to understand the vitamin A being supplemented through government agency or even the private agency?
Yes, sir.
What was it? Only the private or only the government or both private and public?
So not all the private hospitals, they give the supplementation, but all the governments do give, not all the private, sir.
What is the activity from your center by the medical college? Right?
Yes, sir. So it is not given, sir. It's not.
Okay, no, from the department, an outreach activity for vitamin A supplementation or vaccination.
So it is not given free of cost, sir.
Thank you for that.
Thank you, sir. Thank you.
Thank you. Thank you, Dr. Shweta.
Thank you, sir.
Now we shall move to the next. Are you ready? Dr. Christie.
Hello. Hello. Am I audible? Hello.
Yes, please. You are audible. Could you please turn on your camera?
Yes. May I begin? Hello.
Yes, you can start, please.
So should I put it in slideshow? Is it
Yes,
visible?
please. No, put it in slideshow, please. That will be helpful. Anyways, this is in a landscape mode.
Is this visible now?
Is it? Yes. I have put it in slideshow in my laptop. Is that
No,
fine?
no. Actually, we have already shared it from here. Is this okay, ma'am? Dr. Christie, ma'am, you are audible now. Are you able to see us? We are the moderator.
So sorry, I am not able to hear. May I begin?
Yes, go ahead. Go ahead.
We can.
Good morning,
Dr. Christie.
everyone. Good morning. Yes. Good morning, everyone. I'm Dr. Christy Maria, postgraduate student from the Department of Community Medicine, St. John's Medical College, Bangalore. Hereby, I'm presenting a poster titled Prevalence and Determinants of Postpartum Anxiety Among Women Availing Health Services at a Rural Maternity Hospital in South Karnataka, South India. So coming to the definition of anxiety, anxiety disorders are generally characterized by excessive feelings of worry, nervousness, fear, or unease. Postpartum anxiety may interfere with baby-mother bonding, breastfeeding, and infant development because postpartum anxiety results in decreased uterine blood flow, resulting in preterm births and low birth weight of the baby. While postpartum depression has been studied very vastly in South India as well as in North India, studies with respect to postpartum anxiety are very, very few. So there is a paucity of literature regarding postpartum anxiety among rural Indian women.
Dr. Christy, you're not audible. Ma'am, are you here?
Hello.
Yes, ma'am, you're audible now.
Now am I audible?
Yes, ma'am, you're audible
Yeah.
now.
Should I start from the beginning or?
No, ma'am, you can just continue.
Okay. So the study design we have used was a cross-sectional study design with a sample size of 231 obtained from a study done by Shaili Mena et al. Of a prevalence of 17%. We have included the woman from the second day of delivery to 6 months postpartum because the first day immediately after delivery, the woman will be in mild anxiety or other conditions. And the study setting is a rural maternity hospital in Ramnagara district of South Karnataka, which has a population of 496, and the hospital conducts deliveries. And we used an interview schedule with socio-demographic family details, and we have used screening tools as generalized anxiety disorder scale of a 7-item questionnaire and an Edinburgh postnatal depression scale that is a 10-item screening tool in Kannada version. And we have obtained institutional ethics committee clearance to do this study. The method of data collection where women were selected using consecutive sampling, and those women who are currently ill were excluded from the study. The results obtained from the study are the mean age of the study subjects was 23.95 plus or minus 3-4 years, and they have a mean years of education as 11.78 plus or minus 2 years. And most of them, like 82% of them, were homemakers by occupation, and 76% of them belongs to lower middle class socio-economic scale as per Kupiswami's scale. And the table 1 shows the postpartum anxiety, that is moderate anxiety is most in 23% of the study subjects, and postpartum depression they have reported as 74% of them are having no depression. And the table 2 shows an association of postpartum anxiety. We could find only 2 associated factors, that is postpartum depression and alcohol use in husband. We have used chi-square test and Fisher's exact test with a p-value significant less than p-value of less than 0.05 has taken as significant. And we have also done a Pearson correlation test, wherein which the correlation coefficient was 0.036 with a p-value of 0.01. And for every 1 point increase in an EPDS score, there was a 1 point increase in the GAD-7 score. Prevalence of postpartum anxiety was found to be 11.3%, including both the moderate anxiety and the severe anxiety. Postpartum anxiety was significantly associated with postpartum depression with a p-value of less than 0.0 with a p-value of 0.01. And we found there were no associated independent covariates like socio-demographic factors, type of family, or husband's education and husband's occupation. Also, women's education is also not associated with other independent factors. The major limitation of my study is that it is a finding from a hospital-based study and may not be generalized to all the women in the community. So I recommend all the women need to be regularly screened for postnatal mothers and reassurance by counseling and psychiatric interventions. Those are found with postpartum anxiety and postpartum depression. These are my references. Thank you.
Should I go ahead, sir?
So, yeah, Dr. Christie, thank you so much.
Thanks.
Couple of questions.
Yes, sir.
Is there any reason that you pasted? It seems that the tables in your posters were images. Any reason why you could not create those tables? I thought it was looking as an image, at least on my screen. If they're not, that's fine.
Sir, I have put the table in the Word format and then taken the screenshot of it and I've put it because I was not
Nonetheless,
able to. Sorry?
Nonetheless, it's not really visible.
But in my slideshow, it was visible, sir. Sorry for the trouble.
All right. Second thing, you said that one of the limitations of your study was it was a hospital-based study, and as such, some of the factors that you have looked at which could be contributing to the postpartum anxiety and ultimately to depression, you could only assess alcohol use as husband, but you said very clearly that it was not associated with other factors.
Yes, sir. Yes. Sir, could you please repeat?
I want to understand what are the other factors, the social or the socioeconomic factors, as you mentioned, which might be contributing to the postpartum anxiety. Did you assess any of those factors? You simply said that these were not associated with PPA.
No, sir. Actually, while asking the questionnaire, since it is a hospital-based study and in an OPD setting or a hospital setting, we are asking the questions. Most of the women found it reluctant to open up. Like we had questions like whether you have problems from your family side. And also because you are in a joint family, you are feeling very uncomfortable. Such questions, the women were little reluctant to answer. So that is why, since it is a hospital-based study and the woman will be mostly accompanied by the husband or the mother or the mother-in-law, that is why I have told the limitation as since it's a hospital-based study. And other socio-demographic details and family details, what we have looked into is being in a joint family and the husband's education, literacy, and the woman's education. These were the socio-economic factors we have asked for, sir.
Very well. Thank you, Dr. Christie. Dr. Venkatesh, over to you, please. Over.
Christie, the research question is very interesting. And a lot of mental health issues prevailing in the population. It is very relevant in time. Am I audible?
No, sir. I didn't get you.
The question is very relevant. So that is what I want to remember. Okay. So you are, impressing us that this is a hospital-based study, and that is the limitation.
Yes, sir.
If you want to do this in the community, how would you do it?
Sorry, sir. Could you please repeat?
You kept on telling us that it's a hospital-based study, and that is a limitation.
Yes.
So if you want to do a community-based study, how do you do it?
Yes. So, since it's a community-based study, and we'll seek the help from an Anganwadi worker or an Asha worker of that area, and along with her, we will be doing the community-based study because they will be more open up and approachable to them, I guess, sir. That's how we will be proceeding with our study as a household survey.
Okay, you should have done it because you said your study time varied from 2 days to 6 months.
Yes, sir.
First few days they're in the hospital. And as we do understand, almost all of the women do deliver in the hospital itself.
Yes, sir.
So there is no ambiguity in terms of you telling that it's a hospital-based study and that is a limitation.
Okay.
This is what I feel because as we do understand, 100% deliveries are happening in the hospital. And first few days of interaction is in the hospital.
Yes.
And subsequently, it should be in the community.
Yes, sir. But what I meant is, since it's a hospital-based study, it won't entirely represent the community over there. That is what I felt. Yes.
So, did you get what I was trying to?
Yes, sir. I got you.
Okay. Did you apply the same questionnaire after they did go back to the homes?
After they go back?
to their homes. So you
Meaning,
only interviewed them only once, or was it more than once?
yeah. No, we certain individuals where we could not able to gather all the information at that particular time. Maybe for suppose the woman have come with the child for immunization, she will be in a hurry to go. So those times, so those women, maybe the sample size for those women is like only 30 or someone. So for only for them, we have asked these same questions in the community.
Okay. Does the anxiety varied from day 2 to day or 180?
Yes,
That's
sir.
the
It
anxiety.
varied. Yes, sir. The persons who are the three people who are having severe anxiety reported to have the severe anxiety at the month of fourth month. Those three individuals who are having severe anxiety.
Okay. What might be the reasons there?
So because the one reason I could find is they are newly new mothers, and then another reason that is associated with this the child was not able to eat properly, and so those were the severe anxiety women we reported for. When we have asked why you have been more anxious or you have scored more score in this, they have given the reasons like that.
Or is that, was there a reason that they had shifted their homes from mother's house to in-laws' house?
Yeah, could be, sir. And they are not willing to see their husbands as a rural cultural practice. Husband was not allowed to their homes.
Okay, so you have used two scales here, isn't it?
Yes, sir.
Anxiety
Yes, sir.
and depression. So
Yes,
can
sir.
you let us know about the sensitivity and specificity of the scales?
Yes, sir. So the GAD-7, the generalized anxiety depression, generalized anxiety scale has a sensitivity of 86% and specificity of 85%, sir. And whereas EPDS, that is Edinburgh postpartum depression scale, has a sensitivity of 59.5% and specificity of 88.4%. So we could able to distinguish between the true positives and the other ladies.
Okay, thank you. Thank you, Christy.
Thank you, sir. Thank you,
Dr.
judges.
Christie, one parting question. I think while you were having the women in the hospital, I sincerely feel that you could have used that opportunity to ask a few more questions without really invading their privacy and yet trying to understand some of the important determinants of anxiety and depressions.
Yes, sir. Yes, sure, sir. Could I tell you one word?
Yeah, please.
Yes, sir. Actually, when we are going on interviewing the woman, so the one after the other woman is telling others also. So, and some mother-in-laws or mothers feel that we are asking something which intervene their privacy, and they are not really willing to
Open it up.
open it up. Yes.
Yeah.
Okay.
Also, interview technique, it also probably has an important implication on the study design as well, how you design study in such setting.
Okay, sir.
If you had to replicate the same study in a community, while your Anganwadi workers and all the community health workers will be your facilitators, but I think when it comes to the actual interview setting, things may have to be done a little differently. There are also confidential voter techniques. You can actually have exit interviews. You might have a lot of interviews in groups in such a way to probably cull out some of the more generic questions which are important determinants of anxiety disorders.
Okay, sir.
So,
yeah. Thank you, sir.
We shall move to the next. Are you here?
Good morning. I'm here.
Okay. Can you share your screen?
I cannot hear you, please.
Ma'am, are we audible now?
Yes, yes, you're audible now. Can you please share your screen? We are giving you the
Yes,
content. Yes. A moment, please.
Yes, ma'am.
Can you see my screen?
Yes, ma'am.
Yeah, okay. Good morning, faculty, sir. Sir, am I audible now?
Yes, ma'am.
Yes, yes, Renu.
Your time starts.
Yes, sir. So may I start?
Yes, go ahead.
So good morning. My study was titled Complementary Feeding Practices of Children Below 2 Years Age Seeking Healthcare Services at a Tertiary Hospital in Mangalore. So we know the importance of complementary feeding in our country because poor feeding practices are associated with growth and development of infant and toddlers. So so there are fewer studies that look into the diet diversity and diet adequacy of these feeding practices. So in the NFHS 4, they have clearly studied about the complementary practices under these two headings. So keeping this in mind, the objective was to assess the complementary feeding practices of mothers with children less than 2 years of age with special reference to diet diversity and meal frequency. So according to NFHS 4, diet diversity is when the child is receiving at least 4 out of the 8 groups that they have mentioned, and meal frequency will be if they receive at least 2 meals for children between 6 to 8 months and at least 3 meals between 9 to 23 months. So this is a cross-sectional study with a sample size of 200, and mothers who were attending with children less than 2 years of age were approached at the pediatrics OPD and those admitted in the pediatrics ward. This was conducted in Yenapoy Medical College, a 50-bedded hospital, and a semi-structured questionnaire was used for collecting the data, which first part contained socio-demographic profile, second part contained details of the accompanying child like height and weight, and the third part inquired about the complementary feeding practices. And the method of data collection was convenient sampling. So after appropriate ethical approval was obtained and after consent from the mothers and explaining the study, we went on and recruited 200 mothers. So what we did was first the height and the length and weight of the children were measured, and this was put up in the WHO Anthro software, which gave us these curves comparing the male children and female children curve with the WHO standard curve. So you can see that in figure 1, the length for age was compared, and you can see that the male curve is 2 standard deviations behind. Coming to figure 2, it's almost similar. Weight for age is shown here, and in figure 3, length for weight is shown. Now, from the mothers that we were, from the children that we had taken tonight, so taking account diet diversity and diet adequacy, we equated minimum acceptable diet. So from our study, we found that 62 children received the appropriate diet. Now, from those who did not receive, 8.6% only had appropriate length for age, and 37.6% had only did not have appropriate weight for age, and 15.2% did not have appropriate weight for length. For this, less than 2 standard deviations was taken into account. Now, 25% of mothers had already stopped breastfeeding their children before 2 years of age, and 17% mothers have started complementary feeding practices before 6 months of age. Most common foods that we started were 29.5% mothers started with rice, 22.5% started with ragi, and 16% started with biscuits. More than 40% mothers agreed that they started giving bakery items to their children at 6 months of age. By finding the association by chi-square, we found that the minimum acceptable diet was significantly associated with mother's age and number of siblings. Now, one of the strengths of the study is that we have taken length and weight of the children, which was measured in the presence of a staff nurse. So we could compare whether the diet adequacy is actually complementing with the length and weight of the child. The disadvantage here was, as the study was conducted during the COVID times, most of the children who were visiting the OPD was for immunization purposes. So the recommendation here is just advising about starting a complementary feeding practice is not enough.
Ma'am, you have 1 minute left.
To comment on the appropriate diversity of food items, like NFHS 4 mentions 8 categories, and the frequency of feeding and the proportion of feeding should be shown to the mothers, starting from doctors to the grassroots level workers. Thank you. And there's other references.
Professor Venkatesh, can go, sir, please.
Yes, sir. Thank you, Dr. Sangamesh. Rima,
Yes, sir.
so what is your objective?
It was to assess the complementary feeding practices of mothers with children less than 2 years, with special reference to diet diversity and meal frequency.
Assessment of complementary feeding practices.
Yes, sir.
So how is that you have assessed?
So the diet diversity and meal frequency, there is a formulation that is given in NFHS 4 and mother's absolute affection in infant and young child feeding practice, which defines minimum acceptable diet. So that is considered as the complementary feeding practices. And this was compared with the length, weight, and other socio-demographic profiles, sir.
No, diet diversity. So what variables do you have in that?
Sir, for diet diversity, there are 8 groups that was mentioned in NFHS 4. So we did a 24-hour recall method. Once we started asking the mothers, did they give the food or not? So there are 8 groups. First group is infant milk and other milk products. Second group is food with grains and roots. Third is in fortified foods. So that means that second group. Third is vitamin A rich food, which was asked as would they give carrot or mango like that. Fourth group is other fruits and vegetables. Fifth is eggs. Sixth is meat, poultry, and fish and associated items. Seventh is beans, peas, and lentils. And eighth group is food made of oil and ghee.
So have they mentioned the bakery items?
No, sir. That was we asked because they kept talking that they would give biscuits, they would give Mary. So it was a answer they were giving themselves.
But you should have sticked on to the NHS.
Yes, sir. Yes, sir.
And the meal frequency?
So, meal frequency was defined as for breastfeeding children and non-breastfeeding children. For breastfeeding children, they should have at least 2 meals if they are between 6 to 8 months of age, and minimum 3 meals if they are between 9 to 2 years of age. Now, if they are not having breastfeeding, they should have at least 4 meals irrespective of the age with 2 milk feeds.
Okay, if that was getting reflected in your table, you could have added more value to your presentation, I believe. Okay, thank you, Rima. So what do you said? Sangameshwar, sir.
Thank you, Dr. Venkatesh. So, Dr. Reem, how do I say? Is it Dr. Reem or Dr. Amir?
Sir, Reem, sir.
Okay, all right. So one important aspect is, now how do you want to continue this study further? Because I think now, having understood the determinants, what do you think could be the implications? I think you have raised 2 important points here. One is, of course, it's not just enough to sensitize mother about appropriate feeding practices, but also it has to be an emphasis on diverse food items and frequency and proportion of feeding. Could there be any practical limitations in terms of the diversity of food and proportion of feeding from one region to another? The point I'm trying to make here is cultural acceptance of the food items which can be easily sourced from the from available sources in a respondent's area is also equally helpful in determining adequate nutrition of a family and especially children.
Sir, that's a very important point, so that we had come through. Actually, the 8 categories that I had, 2 categories were non-veg items. One was eggs, and another group was meat, poultry, and fish and associated items. So these 2 categories are automatically not being given to for children who follow a vegetarian diet. So the NFHS, this is actually we are taken as directly for NFHS 4, so we didn't try to change it. Another thing is that. Yes, sir.
I think you could have, because I think the tools or some of these standardized tools that are given probably might also need some tweaking purpose, isn't it?
Yes, sir.
Yeah. So
I
you were
didn't
saying
find
something.
Yes, sir. I didn't find any similar studies, so I thought I would do a fresh, same thing. That's why, sir, I didn't tweak anything. And another thing, sir, I think that a proportion of the food they were feeding is also important. They may feed 2 times, but it may be 2 spoons or one katori. So that is also they have this proportion of food is mentioned in the study, but it is not included in assessing the feeding practice in the NFHS 4, sir. And
Right.
diversity, yes, the diversity is important. So the main thing I mentioned bakery was because every time we used to ask about vegetables, they keep saying that they used to give fortified foods and they used to give biscuits and all. So they used to replace the answer instead of yes and no. So the diversity is something that they have to be sensitized to it and then provided to them. So.
Right. When you said diversity, I know Dr. Venkatesh asked you this question. How exactly did you assess the diversity? And you also answered that you have used the NFHS scale, the criteria. You had asked what was fed to the child last day, or there was a one-day recall. But my question is, did you use any other specific tools such as food kind of images to help?
Sir, no, sir. We didn't use any tools, but we made sure that we made the mother comfortable by talking their local language. So here Tulu and Kannada is there. So we, the medical social worker was with us to explain the questions in their own language, sir.
Very well. Thank you, Dr. Thank you.
Thank you, sir. Thank you, sir. Thank you for the opportunity.
That's good.
So now we should Are your audio difficulties dealt with now, sir?
Excuse me, am I audible?
Ma'am, are you able to speak?
Yes, you are audible.
Yes, ma'am, you're audible.
Okay, thank you.
Can we continue?
So can we move on to Dr. Preeti ma'am's presentation because we're not able to get Dr. Syed back.
Yes, go ahead. Go ahead.
Ma'am, we should be sharing.
Yeah, okay, thank you.
Is the screen visible now?
Yeah, it's visible.
Okay, your time starts now, ma'am.
Okay. Good afternoon, respected judges and other delegates. I'm Preeti Ashok Masli, final year postgraduate of SSIMS RC in Davangere. The title of my study is Awareness about Food Labels on Packaged Foods among the postgraduate students of a medical college. So, as we all know that sedentary lifestyle and unhealthy dietary habits raise the risk of non-communicable diseases such as obesity, hypertension, diabetes, coronary heart diseases, so on. So, since with the reduction in the prevalence of various communicable diseases like dengue fever, malaria, and so on, now it is important to focus on the non-communicable diseases, which is there is rise in the prevalence. So, in preventing this epidemic of non-communicable diseases, medical students or faculty play a very major role as their knowledge about nutrition along with the healthy behaviors, it can improve the overall nutrition of the community and also can lead to a better and healthier society in future. So the objectives of my study were to assess the awareness about food labels on packaged foods and to enlist the reasons for not checking food labels on the packaged foods. So the study was a cross-sectional study which was conducted on 120 medical postgraduate students of SSIMS, of all departments of SSIMS, Oxida and Dere. The data was collected using a pre-designed, pre-tested questionnaire. So coming to the results, out of total 120 postgraduates of all the departments considered, 55% were females and 45% were males. Majority, that is 98% of them were Hindus and most of them were vegetarians, and labels over the packaged foods were always checked by only 41% of the postgraduates before purchasing these packaged foods. Can you zoom into the table 1, please? So the table 1 showing information about food labels, it shows that a majority, that is 73% of them stated that nutritional information will be provided in terms of per 100 gram or per 100 ml on the packaged foods. And about 93% of them stated that agreed that the nutritional information should be provided on the packaged foods mandatory, and only 13% of them stated that ISI logo is mandatory on the packaged foods. As we all know that right now ISI logo is mandatory only on certain products like household electrical equipment, cement, baby formula, and other processed cereal-based foods, and also water packages. Okay. Next, when asked is providing AGMARK logo on which products it is provided, then 47% of them stated that it is provided, it is seen on agriculture products. And can you scroll down, please? 88% of them gave a green color as a color code for vegetarian packaged foods, and about 18% of them said brown as a color code for non-vegetarian packaged foods. So can you scroll right towards right, please? Excuse me. Yeah. Okay, the next figure, that is showing the reasons for not checking labels on packaged food. It shows that majority of them said lack of time is a reason for not checking labels over the packaged foods. Yeah, the most common nutritional information was checked for. Can you roll down, please? Scroll down, please. Yeah, you can zoom out, please. Yeah. Okay, the most common nutritional information checked was for energy, followed by fat and carbohydrates. And the most common general information looked was for date of expiry, date of manufacture, followed by price of the product and the best before use date. The limitation of our study was sample size being less. And I conclude by saying that despite having positive attitude and satisfactory knowledge about food labels, they were not checked regularly due to lack of time, trust for the brand quality, and small font size. And I would like to recommend that health education regarding food labels for the packaged foods should be included in the curriculum. These are my references, and I thank all the participants for participating.
Your time is up now, ma'am.
Thank you.
Thank you.
Yes, sir.
Yeah, thank you, Dr. Preeti. Dr. Venkatesh, if I may.
Please go ahead, sir.
Question, why did you select only the postgraduate students? Is there any particular reason why you chose them? And was there any other consideration within selection of postgraduate students as to how many of them were day scholars and how many were hosteliers?
No, sir. Actually, the postgraduates will be practicing, I mean, seeing the patients in the OPDs and all. So I just wanted to check their awareness regarding food labels, which can be given as a health education to all the patients who visit the OPD. Since the limitation of the study is also, I just considered a postgraduate study, so the sample size is less. Even in terms.
Do you think that might have been an important consideration?
Sorry, sir.
Do you think to understand who was actually a day scholar? The point I'm trying to make here is, first and foremost, when you say the consumption of packaged food,
Yes, sir.
have you made any distinction of pre-processed food, such as food grains or any other food which is yet to be processed versus processed food which is in a ready-to-eat condition? Do you think that might have an important implication in trying to draw your conclusion?
Yes, sir. It plays an important role, but I didn't make any distinctions. Sir.
And what have you done to clarify that point in your research?
Sorry, sir. I didn't make any distinctions like processed foods or pre-processed foods. I just wanted to say that this health education regarding food labels on the packaged food should be included in the curriculum. Since the rise in prevalence in the communicable disease, non-communicable diseases, it is important to, it can be useful to focus on these things. So, since the packaged foods are easily available, they are consumed more, sir, and because of lack of time, more students and even the youth, they are more attracted towards this packaged foods, sir. So there is a rise in prevalence, rise in the obesity, coronary heart disease. As we all can see, the deaths due to various cardiac causes or obesity in the
No, I
youth.
understand. I get that. I get that, Dr. Masli. What I'm trying to understand here is what amount of, or rather, do you think that would have been an important consideration in selecting your respondents as well as to what is the frequency of consumption of packaged food? Because at least as far as I can recall, if I'm a hostelier, I would rather be eating most of the time in a mess, and obviously there will be the X number of times that I will be eating outside. In that, I would be eating Y number of times from a packaged food. So I think if you had made that clear as a context to the research, maybe it could have helped. Because I honestly am still not very sure whether simple awareness of the package insert on packaged food is sufficient enough to probably help anybody go to the actual details of the kind of food that they are eating. But these are again my thoughts. But again, I would probably ask also my colleague Dr. Venkatesh to weigh in here. Over.
Thank you, sir.
Dr. Priti,
Yes, sir.
did you try to understand the quantity of processed food that being consumed by our postgraduate students?
Yes, sir.
Now, did you try to assess how much of?
No, sir, I didn't.
Because you said consuming processed food has an impact on chronic non-communicable diseases.
Yes, sir.
So, what quantities have to be consumed for it to be harmful? Is there any information on that? The literature, available literature?
I didn't ask regarding this.
No. In the available literature, did you have such information?
No, sir. Regarding quantity, I didn't have the literature.
Okay, so it was good to know that people are aware, like a big proportion of your study participants were aware
Yes,
of
sir.
the processed food, and they were trying to look into the content so they understand what green cover means.
Yes, sir.
Isn't it? So, do you plan any intervention here after you have done your study? So, do you want to try and make your participants more aware of what they need to look into or what they should be eating as processed foods?
So intervention can be done like checking for BMI after certain period. Any morbidities which are usually less in the age, but BMI can be considered. So
Okay. This was just a question-based study, so there was no.
no, sir, it was not intervention based. So.
You did not try to understand their BMI or blood pressures or sugars.
No, sir, I didn't look for those things.
And I think there was no opportunity for you to go out of the campus.
So there is an opportunity, sir, but I just wanted to know how first frontline workers like health workers have the awareness regarding these, so that we can educate the people.
What was the duration of your study?
3 months, sir.
3 months. Okay. Right. Thank you. Thank you.
Okay. Thank you, sir.
Thank you. The judges are done with their questions.
Thank you, sir.
The last participant, batch ID 0119, Dr. Syed. Are you ready? Dr. Syed? Yes. Dr. Syed?
Yes, madam.
Yeah, you can start now. Your time starts now.
Yes. Good afternoon, sir. My poster title is a descriptive cross-sectional study on internet addiction among the medical students of Kakatiya Medical College, Warangal, Telangana, sir. Coming to the introduction, sir, there has been an explosive growth in the use of internet, not only in India, but also worldwide in the last decade, sir. Medical colleges in both developing and developed countries are utilizing educational to bring effective changes in medical education. College students are a group particularly vulnerable to the internet addiction because of their unique personal, social, and academic needs. And factors like the lack of parent control, exams, and peer stress often leads to a pathological internet usage. Internet addiction is a mental illness affecting many individuals surfing online. The objective of my study is the study was designed to evaluate the prevalence of internet addiction among the medical students and to study the degree of or level of internet addiction among the medical students. And the methodology is the cross-sectional study was conducted among the medical students of Kakatiya Medical College for a period of 2 months. The sample size, a sample of 210 was estimated using the prevalence of internet addiction at 58.87, sir, with relative precision 12% and 10% anticipated non-responders, sir. First, the students were stratified. These students were enrolled by two-stage sampling techniques, sir. And first, students were stratified according to the year of academic courses, sir, first year, second year, and third year. Then the required number of students were selected by simple random sampling method from each group so that each academic year will have equal presentation in a study sample. And the data was collected by using a semi-structured questionnaire consisting of questions related to demographic information related to the internet use, and Young's internet addiction scales. And the inclusion criteria was history of using the internet from past 6 months or more and willing to give consent. And data analysis was analyzed using EpiInfos. The results showed that showed in the studies prevalence of internet addiction among the students was found to be 93.9%, and among the study students, that level of internet addiction, 68.5% had mild addiction, sir. 21.9% had moderate internet addiction, sir, and 3.3 had severe internet addiction, sir, and 6.1 had no internet addiction, sir. And according to their residence of students, sir, hostlers had more internet addiction, sir. And the students residing in private accommodation had 12.9%, and the students residing in their home had only 10.9% internet addiction, sir. If we go on specific among these hostlers, the degree of internet addiction, sir, students had mild internet addiction about 84.7, and moderate about 11.12, and severe 0.66. And among the students residing in private accommodation, they had 27.58 mild internet addiction, and 48.27 moderate internet addiction, and 17.24 severe internet addiction. And among these students who were residing in their homes had 26.6% mild internet addiction, and 46.6% moderate internet addiction, and 3.3 severe internet addictions. Among these, hostlers are the private accommodation or students residing in their homes. The students who were residing in private accommodation, they had more severe internet addiction, sir. It is about 17.2%. And the gadget used to internet addiction, as all we know, sir, smartphones about 71.4%. And the conclusion, coming to the conclusion, sir, the result highlights the vulnerability of medical students to internet addiction, and efforts should be taken to increase awareness and prevent the problem in them. And these are my references, sir. Thank you, sir.
Sir, with your permission, should I start?
No, please, kindly go ahead, Dr. Venkatesh. Thank you.
Syed, it's a very good question that you have tried to address.
Sir, thank you, sir.
You said the addiction, people without addiction is 6%.
Yes, sir.
Okay. So, how is that you have defined the addiction?
Addiction, I defined with this internet addiction scale is there, sir, by Dr. Kimberly Young, sir.
Okay,
that scale I used to measure addiction of internet.
So how many questions are there in that scale?
In 20 questions are there. 20 questions, and it is a 6 Likert scale, sir. And based on the scoring is there, sir. IIT scoring up to 0 to 100, sir. 0 to 20 is normal, no addiction, sir. From 30 to 49, it is mild, sir. And 50 to 79 is moderate, sir. Above 80 is severe addictions.
Dr. Syed, is there any specific question that talks about the exposure time is what Dr. Venkatesh is trying to understand in young scale? We just need to understand the young scale a little bit more, because 6 months in our view probably may be misleading to actually call an addiction, especially with the issue of internet. So are there any specific questions in the young scale which talk about the exposure to internet to call it as a real addiction?
It is a similar question is there. How often did you choose to spend more time on online, ever going out with others? This question is included, sir.
So when was this scale designed?
It was designed in 1995, sir.
So this is almost 25 years now.
Internet has come a big age in the past 25
so many
years.
changes.
And more so in the recent COVID times. Perhaps if you talk to any onlooker with internet exposure, probably 6 months, they will definitely scoff at you.
Right, sir. Right, sir. I admit.
Okay, so you also said there were three who were severely addicted.
Sir,
Is it three or two?
sir, three, sir.
Three. Okay, so why did you like what are those features that you could appreciate in them?
Sir,
No,
I
based on
couldn't
the
get.
questionnaire, you assess them to be seriously addicted. But through your observation,
So depending on the score,
of course, correct. But whatever you could appreciate in those severely addicted, what were the
sir,
impacts that you could understand? Impact of assessment
sir,
on
they are
students and health.
academically they were back, sir, as seen in recent reports in their progress reports, sir.
And what were their
And they
absenteeism?
were, sir,
What were their absenteeism? Not attending to
not
regular classes
attending
or
the
such.
college, sir, absent. They were
For how long? For how
frequently
long?
absent, sir.
Did you look into their attendance registers?
Yes, sir.
So what were their attendance percentages?
Are you, how did you manage that, Dr.
Attendance,
Sayed?
sir, their attendance was around 55%, sir.
Sir, you asked something. Go ahead, sir. Sangamesh, sir. Oh, 50% is not very bad.
The methodology itself, because and I think you have in between most of
Sir.
your questions, I was able to also carefully insert my questions, and I don't have any further questions.
Okay, sir. Thank you, sir.
Thank you, sir.
That was the last participant for today. Down to the end.
Thank you to all the participants for taking part. And thank you to Dr. Sangameshwar sir and Dr. Venkatesh sir for judging this event. Thank you for your insightful comments, sir, regarding all the participants' posters. And thank you for all your time.
Thank you. So how do you?
Thank you.
Thank
Yeah, I
you.
was about to ask that. I was about to ask, is there a way that I can concur with Dr. Venkatesh before we submit our scores?
Yes, sir.
Yes, sir.
We can send you his contact.
Yes, sir. We can.
No, I have his contact. Don't worry. So I'll connect. So Dr. Venkatesh, is it okay if I can connect with you immediately after this for about 5 to 10 minutes?
Yes, sir.
Just so
Yes,
that
sir.
we align on the scores.
Yes, sir.
Thank you so much. Thank you. I'll call you, Dr. Venkatesh.
Yes, sir. Thank you.
Thank you, sir.
Thank you, sir.
ಅಪ್ಪ ಇಷ್ಟೊತ್ತಾಗ್ಬಿಡ್ತಲ್ಲಪ್ಪ
Can we leave?
What is the rationale behind what you want to do? So I told him everything I'm doing.
Good afternoon, all. I'm your moderator speaking. I'm going to do a roll call. Is catch ID 97, Dr. Sucharita here? Dr. Sucharita, if you're here, please respond. We can't hear you, ma'am. Dr. Sucharita, if you could respond. Are you here, ma'am? You're not audible, ma'am. Still not audible. No, ma'am. Okay. I'll move on to the next person, and you can fix your audio by then. I'm not. This is just a roll call. This is just to see if your audio is working. Dr. Jyoti, sorry, 25 here.
Yes, ma'am.
Okay. Dr. Anupama, 44. Dr. Anupama. ID 147.
Yes, ma'am.
Dr. That's ID 155.
Yes, ma'am. Yes, ma'am. Present, ma'am.
Dr. Sima, that's ID 230. Audio issue. Dr. Sucharita, ma'am, if you could unmute yourself and let's see if your audio is working. Okay, ma'am.
Hello. Hello.
Yes, is this Dr. Anupama?
Yeah, I am Anupama.
Yeah, ma'am. We'll just,
Hello.
Dr. Anupama, are we audible to you?
Hello.
Ma'am, can you hear us? Dr.
Yeah,
Anupama?
yeah, yeah.
Okay, ma'am. You can mute yourself now.
Okay, okay.
Dr. Sucharita, you're still not audible, ma'am. No, ma'am, we still can't hear you.
Hello, ma'am.
Yes, ma'am, we can hear you now.
Okay, ma'am.
Okay.
Share option is not visible, ma'am.
Yes, ma'am, we'll give it to you shortly once we start the event.
Okay, ma'am.
We're waiting.
Hello.
Yes, ma'am.
I have some technical issues with my laptop. I can't able to connect through my laptop. I'm connecting with my phone. I can't able to share my PPT. Can you put up the PPT? Hello.
Yes, ma'am, Dr. Anupama. You haven't shared your PPT with us, ma'am. So you should be sharing it from your end.
But I
Because we
can't
haven't
able.
gotten an email from you with the PPT.
What?
We haven't gotten an email from you with your PPT, ma'am.
You haven't got it.
No, ma'am.
Can I send it now? Hello.
Okay, ma'am.
Okay. Thank you. Hello. Hello.
Yes, ma'am.
I have sent my PPT. Please, can you
Ma'am,
able to download? You got it?
Send the
Hello.
PPT slide.
Hello.
Yes, ma'am.
Can you hear me?
Yes, ma'am.
You got my mail?
No, ma'am.
That scientific. Hello.
Oh, ma'am, if you can please check your chat box on WebEx. Given you a mail ID, you can mail it to.
That yeah, I have sent scientific
No,
CatchCon
so
2020.
send it to Holiday Chat.
Hello. Hello.
Can you please mail your presentation to this mail ID, hallacatchcon@gmail.com?
hallacatchcon@gmail.com. Okay.
Yes, ma'am.
Full capital or what?
No,
Just
ma'am,
send it
all
to you
small
on the
letters.
chat.
Ma'am, all small
A,
letters.
even A is also small. Hall A.
Yes, ma'am. Yes, ma'am, it's a small A.
Okay. 2020 or catchcon@gmail.com.
Yes,
Hello.
ma'am.
Hallacatchcon@gmail.com.
I have sent it. Can you please check out? Hello?
Yes, ma'am, we got it.
Yeah, please share that one. I couldn't share it by
Okay, ma'am.
laptop. I have a problem. Thank you.
Thank you.
Can we start the session now?
Yes.
Sorry, ma'am, Dr. Ma'am, the other will join. We are waiting on him. Dr. Ramesh has to join the meeting.
Okay.
Dr. Pavitra, ma'am, can we start the session without the other judge and proceed? And he will join later on.
Yeah, I don't mind. If it is okay with you people, I'm okay.
Well, no waste time. Will be starting now?
Yes, we can start.
Good afternoon, everyone. Welcome to the 32nd State Level Annual Conference of Karnataka Community Association of Community Health, this year hosted by Ramaya Medical College, Bangalore. So the theme for this year is redefining public health, COVID-19 and beyond. With this, let's begin our session, which is a presentation for PG. Let me take this opportunity to introduce our two judges for today. Dr. Pavitra, sir, BJ Institute of Medical Sciences, and Dr. Ravish, Professor from KIMS Bangalore, who will be joining us shortly. Ma'am and sir, thank you so much for taking time off your busy schedules to judge this session, and we are very thankful. So, moving on, let's go over the instructions for today's session. Participants, you might have already seen this instructions that were sent to you. The most important instruction of all of these is to keep in mind your time limit, which is 6 minutes, plus 2 minutes for question and answers with the judges. And we, the moderators, will intimate you 1 minute prior to the end of your time. So today's session will be moderated by the two of us. I am Deepti.
And I'm Aparna.
We are third-year students from Ramaya Medical College. So let's start the session with the first participant for today.
Dr. Are you here?
Whom we will be giving you control now to share your presentation. Yes, ma'am, your time starts now, and please put your presentation on full screen mode.
Okay. Good afternoon to all the professors and teachers, and all the judges. Myself, I'm Dr. Sucharita, first year PG Community Medicine Department of Kakatiya Medical College. I feel highly privileged to be a part of this conference, and I come up with a topic here, evaluation of breastfeeding practices among mothers in slum area of Warangal Urban, Pedamagada. Despite the demonstrated benefits of breastfeeding prevalence and duration in many countries are still lower than the recommended of WHO for exclusive breastfeeding in the first months of life. In India, the rates of early initiation of exclusive breastfeeding are far from recommended. The objectives being evaluation of breastfeeding practices amongst mothers in the slum area of Pedamagada. Methodology. The study design is community-based cross-sectional study, and it is in the urban field setting practice area of Kakatiya Medical College. The duration is 2 months, and the study population women more than or equal to 20 years of age. The sample size is 408, and sampling is simple random sampling method. The study tool is a semi-structured questionnaire prepared with the help of previous literature. Data collection and analysis. Data was entered in MS Excel and analyzed using SPSS 20. Results. Age distribution of mothers. Percentage of mothers who were in the age group of 20 to 25 years are 61%, and percentage of mothers in the age group 26 to 30 are 39%. Distribution of prevalence of breastfeeding. Exclusive breastfeeding for 6 months. The prevalence is 8.9%, and breastfeeding up to 1 year, 24.6%. Breastfeeding up to 18 months to 2 years is 33.2%. Overall, exclusive breastfeeding up to 6 months is 63.1%. Prevalence of exclusive breastfeeding on the whole is 63%. And here I come up with the conclusion. It's high time to create intense awareness about breastfeeding and intensify educational programs. Launching of breastfeeding campaigns. Motivation to mothers right from the PHC level. Creating awareness about the concept of rooming in. That is allowing the mother and the child to remain together for 24 hours. And emphasizing early initiation of breastfeeding. Educating the mothers about foods that enhance lactation and the recommended protein and calorie intake per day. Detailed counseling to mothers along with the demonstration of proper latch-on positions, which could build confidence in the mother to adhere to breastfeeding for longer durations. Thank you.
Thank you, Dr. Suchitra.
Thank you, sir.
Okay. I have a few things to tell you, the suggestions basically. Your conclusion should be based on your objectives and the study. What you have given, all these things are general conclusions because you told that you have to create awareness, first one. You don't know their KAP, you have not done it. So whether you know or don't know, that is the matter, because once you have done this study, you know the prevalence of breastfeeding or exclusive breastfeeding. You should know what are the factors which is related to not following exclusive breastfeeding. That would have been a better study. Yeah. So similarly, the other things also, detailed counseling of mother, motivation to mothers right from the PHC level. You have not studied all these things, whether they have done it or not. Rooming in and all those things. So all these things, when you don't know whether it has been done or not, you cannot come to conclusion. Whatever you have studied in your under your objectives in your presentation, it should be the conclusion. Is it clear?
Okay.
That's all from my side.
Thank you, sir.
Thank you.
Dr. Suchitra, you have taken an effort and you have gone to community also to do this study. You could
Yes,
have
ma'am.
done a closing session, like you could have collected all these mothers who are coming to your center, and you could have given them a health education session, and you could have promoted breastfeeding, and you could have taught them better breastfeeding practices. All
They
such
have,
things can be done.
I have
You have
given,
done that.
yes, ma'am.
Yeah, and so you could have evaluated how their knowledge improved post your session. What was their knowledge before your session? Some things like this you could have done. How helpful your session was for them.
Okay, ma'am.
Okay, thank you. Thank you.
Thank you, ma'am.
Budget for the question. So do you have moving on, the next participant is catch ID 153, Dr. Jyoti Singh. And will be sharing my your PPT? Or would you like to share it yourself?
Yeah, I would like to share my PPT, ma'am.
Ma'am, we
Can I
shall
get?
give control. 1 minute.
Yes, ma'am.
Ma'am, we have given you control now.
Yes, ma'am. I'm just sharing my PPT.
Okay.
Ma'am, your time.
Yes, ma'am. Just a few seconds, ma'am. Can we? Can we minimize this? Can I start, ma'am?
Yes, please.
Go ahead.
Yes, ma'am.
Yes. Yes. Good afternoon. Good afternoon, respected sir and madam. My name is Dr. Jyoti Singh. I'm final year postgraduate student, and today I'm going to present to you all my research work on 3-delay model of maternal morbidity and mortality in 2 tertiary care hospitals of Belagavi. I've done this study under my professor and research guide, Dr. Chandra S. Medkut, ma'am, Professor, Department of Community Medicine, JN Medical College, Belagavi. So coming to introduction and objective, every year millions of women around the world suffer from pregnancy, childbirth and postpartum complication. Approximately 8-10 women die every day worldwide from preventable causes related to pregnancy and delivery. Hence, the 3-degree model forms an important component in assessing poor maternal outcome to understand the gap in access to adequate obstetric management. Delays in access to quality care have been identified as one of the important determinants of preventable maternal death. The objective of my study is to find out the 3-delay model leading to maternal morbidity and mortality in 2 tertiary care hospitals of Belagavi. Coming to material and method, this was a cross-sectional study conducted for a period of 1 year in 2 tertiary care hospitals of Belagavi, namely KLE Charitable Hospital and Civil Hospital Belagavi, among antepartum, intrapartum and postpartum mothers experiencing severe maternal outcome. The sample size was calculated using the prevalence of maternal near-miss incidence ratio of 20 per 1,000 live births from detailed research through literature, and it was calculated as 200. Data was collected using modified facility-based maternal near-miss review form based on WHO M&M criteria 2009, and written informed consent was obtained from each participant. Statistical analysis was done using chi-square test, univariate and multivariate logistic regression analysis. Coming to the results, socio-demographic profile, the mean age of my study participants was 25 years, ranging between somewhere between 21 to 29 years. Majority were literates, that was 90.5%. Almost half, that is 52.5%, belong to class 4 and class 5 socioeconomic status, according to modified BG Prasad. And majority were referred to the study hospitals, 80%. And mean duration to reach the first health facility from home was 12 hours, lying in a range between 2 to 22 hours. And from first to current health facility was 12 hours, lying in a range between 0 to 24 hours. What I would like to note here is that the mean duration which took from home to the current study hospitals were somewhere between 0 to 48 hours, which is about 2 days. Coming to obstetric profile, 69.5% cases were unbooked at the study hospitals. 56.5% had less than 4 ANC visits, and almost half were primary gravida in my study, and majority had anemia, that was 86%. Coming to the M&M profile, 83.5% had severe illness. Now, in order to become eligible to be called as a maternal near-miss, they had to have clinical, laboratory, and interventional criteria. So, I found that conversion was seen in about 17% cases. Severe anemia consisting of HP less than 5 gram per DL was seen in 25% cases, and ICU admission was seen in almost half of the study participants. And most common near miss event was obstetric event, which was 76.5%. On calculation, the MNM-IR in my study was 12.05 per 1,000 live births with 47 maternal deaths. And MNM is to maternal death, the ratio was 3.3:1. That means there was one maternal death for every 3 to 4 maternal near miss cases, which comprised of severe life-threatening conditions. Coming to the types of delay, I have studied type 1, 2, 3 and 3 delay, where we found that type 1 and type 2 delay was seen in about 65 to 67% cases, and all the participants which had come to the study hospital had faced type 3 delay. And looking at each component, we see that 82% of my participants had both lack of awareness and resources in the study, and remaining type of delays were seen in a range of 30 to 35%. Coming to the graph 1, which shows the type of delay and maternal outcome. Here we see that maternal mortality was seen in 30.6% of the study participant with lack of awareness, and in 30.1% of the participant with lack of resources, and this association was statistically significant with p less than 0.05. Similarly, in graph 2, we see that the second type of delay, that is delay between healthcare facilities, had the ones who had faced delay were about 33.6% who underwent mortality. Again, in type 3 delay, we see that maternal mortality was seen in 31.7% of the mothers with the lack of instrument or medicine. Similarly, poor infrastructure also contributed towards the delay, and which in turn contributed towards maternal mortality of 31.6%. On all these associations were statistically significant. So on further subjecting this to univariate logistic regression analysis, we found that type 1 delay and type 3 delay were about 2 to 3 times more likely to end up with poor maternal consequences, whereas type 2 delay, which was delay between healthcare facilities, was 4.3 times more likely to end up in poor maternal outcome with a significant p-value. On further multivariate, we found that the delay between healthcare facilities, which was the type 2 delay, had an adjusted odds ratio of 7.6. That means they were 7 times more likely to end up with a poor maternal consequence. Hence, to conclude, type 3 delay was noted in all the MNM cases who were referred. Almost 2/3 of the MNM mothers faced type 1 and type 2 delay, and women who experienced any kind of delay during their pregnancy were 2.5 to 7 times more likely to end up with poor maternal consequences. Hence, I would like to recommend that there has to be proper awareness and training of the healthcare workers right at the grassroots level, so that they are aware and they know about the severe maternal consequences, and they can guide the patient and the family to as in where to go and which facility to approach during any crisis, and strengthening of the referring facilities so that early and prompt referral will lead to saving time and prevention of these preventable deaths. Thank you.
Okay, thank you, Dr. Jyoti.
Thank you, sir. Yes, sir.
There are one or two questions for you.
Yes, sir.
First one, where is the problem here in your study?
Sir, I believe the problem lies in the logistic part. Like when I conducted the study for a period of 1 year, I found that people are either hopping from one facility to another, going against medical advice, etc. So they are wasting their time there, and by the time they reach a tertiary health facility, they have already crossed 1 day or 1.5 days, sir, and the problem has already increased. The morbidity level has increased, sir, which had resulted in mortality in some of them.
Why the most of the PHCs, primary health centers, are converted into 24/7? Okay.
Yes, sir, that is
And
one
the
of the
instruments
reasons,
and the
sir, right.
facilities are available as on date, as far as I know. And reaching the tertiary care hospitals are not difficult, especially in Belgaum, because that side Hubli Dharwad is there, Belgaum is there,
yes,
Kolhapur is there for the other side. So it is easier for them. The only thing is there any lack of the skills of the base level workers there?
Right,
Are they
sir.
not doing anything? Because all the mothers are registered, no?
Yes, sir, all are registered, but sir, like in PHC level, when they come, even if the healthcare workers are not trained enough, or they don't know exactly where to send them. For example,
No. They will be knowing where to send. A referral will be there, and the ambulance are also there. everywhere. So please look into the logistics issue where it is problem,
Yes.
and you showed regarding the instruments also. There is
Yes, sir.
problem with
Medicines and
instruments
instruments.
where,
Yes.
where?
Sir, at the referral center, which is referring them to which had referred them to our study center, sir.
Do you
Like
think?
if they came from a PHC or from a nursing home or from a dispensary, so there was an infrastructure issue. For example, it was just a daycare center, or there was no provision of giving them
No,
blood
nothing like
transfusion.
daycare center is there now. Anyhow, please look into all these things. Thank you.
Yes, sir. Yes. Thank you, sir.
Dr. Jyoti, what was the limitation of your study?
Ma'am, the biggest limitation was it was a facility-based study. I had only taken from my hospital and from the district hospital here. And since some of the cases I had to take on record-based, so if all the investigations are not written clearly or some data was missing, so that was one problem.
Okay. You had mentioned that unregistered pregnancy around 67%, isn't it? Somewhere around some. Yeah,
Yes, ma'am. They were
unregistered.
unbooked.
You meant
Unbooked
unbooked. You
cases.
meant they
Yes,
were
ma'am.
not booked with your institutions,
Yes,
or
ma'am.
they were
Not
not
booked with our
your,
institution, neither with our or with the district hospital.
but they were going
They
to
were
any other
registered,
private.
ma'am. Yes, ma'am. The ANC was registered somewhere, wherever they had shown in the previous months, but at that time they were not, not with our hospital.
Okay. Okay. Thank you. Thank you, Doctor.
Thank you, ma'am.
Thank you, Dr. Jyoti. We'll move on to the next presentation. Dr. Anupama. We'll be sharing your screen.
Yes, please share my screen. Good afternoon, judges. This is myself, Dr. Anupama K, a postgraduate student, final year from SSIMS. My title of the study is Awareness about the Contents of the Mother and also the Child Protection Card among pregnant and lactating mothers of the rural area. Change the slide. Next. Change to introduction. Introduction, next slide.
Hello.
Introduction. India has
Sir, ಇಲ್ಲಿ
recorded a momentous
ಕಾನ್ಫರೆನ್ಸ್ ಅಲ್ಲಿ ಆನ್
reduction of
ಬರ್ತಾ ಇದೆ.
deaths and also the mother and infants. So, according to the latest survey, there were about nearly 84.1% of the pregnancies were registered and 73 had received MCPC cards. And mothers and also like MCH program in the country, it is the aims to reduce the maternal and also neonatal under 5 mortality and morbidity. So with the National Institute of Public Cooperation and in collaboration with the UNICEF and Ministry of the Women and Child Development, they had introduced this MCPC cards. So in Indian setup, the maternal and also child health problem is because of this unawareness, poverty, and also the lack of scientific knowledge. Though all these details are given in the MCPC cards, the utilization of card is being done only for recording information, but it is not utilized. Please change the next slide. Objectives of the study is to describe the socio-demographic profile of the study subjects and to assess the knowledge and contents of the MCPC cards among the pregnant and lactating women of the rural area. Next, materials and methods. Methodology. The study design was a cross-sectional study. It was done for a period of 2 months and it is done in the Lokikere PHC. Size is all the pregnant and lactating mother during that period was taken, that is 161, and studies samples all the pregnant and lactating mothers less than 1 year were included. Next slide. Inclusion and exclusion criteria. Inclusion criteria, it is all the pregnant and lactating women aged less than 1 year, and also mothers who are willing to participate in the study was included. Exclusion, mothers who do not had a MCPC cards, and those who are illiterates, unable to read and write, was excluded. Data collection, a list of the pregnant women seeking antenatal services and mothers of the children aged less than 1 year were the beneficiaries of PXs. These were obtained and included in the study. House to house visits was done to get the information from the study subjects. Next, data collection and analysis. Next slide. The questions to obtain the knowledge was drawn with reference to the MCPC card. It covers the ANC, that is antenatal care, immunization, nutritional status of the child, and growth monitoring, and prevention of some of the certain diseases, important diseases. And scoring of this knowledge was done, especially for every correct response, the score of 1 was given, and incorrect response 0 was given. So maximum minimum scores was obtained, that is 22 and 0. Adequate knowledge, those who scored more than 17, and inadequate knowledge, those who scored less than 17 was considered inadequate. Analysis was done by using the SPSS version 10, and it was represented in the form of frequencies and percentages. Next slide. Results. Socio-demographic details of the study subjects. Majority of the study subjects were from the age of 19 to 24 years, that is about 39%. And their education, basically their majority had done till 10th standard, 59%. And majority were homemakers, laborers, 46.5%, and majority were from Hindu religion, and majority from the class 3 socioeconomic status, and they were from joint family. And regarding this antenatal care, most of them were, all of them had MCPC cards, and they had found it useful. And minimum number of antenatal checkups needed, around 4.9% had known, and hemoglobin tests only 2.4%. Yeah, and blood pressure test, it is 4.9, and weight gain during second and third trimester is 43.4%. Vaccines 92%, and vaccines, which are the vaccines to be given, this is also the same. And iron tablets consumed during pregnancy, minimum number is 72.6%, and danger signs is 91%. They have told pain abdomen, and preparations, most of them are not answered, 57.7%, and ideal gap, it was 48%. Post pregnancy signs, it was around 62.7%. They had answered a fever. And care for the newborn, majority had known breastfeeding, 92.5%. And danger signs of newborn, a majority of them answered hyperthermia, 44%. And food items, knowledge about the newborn care. The food items used in the complementary feeding, 90%, they have told cereals, and majority.
Time is up.
Yeah, I'll conclude. Those who are found adequate knowledge was about 18.6%, and remaining 81.4% had not inadequate knowledge about. So to improve the community awareness regarding the MCH services, information, education, communication activities should be increased through the campaign media and also mass media like television. And they need to motivate women to utilize the MCH.
Ma'am, your time is up. The judges can ask you questions.
Yeah. Thank you.
Judges, you can ask your questions now. Yeah.
Hello. Yes, ma'am.
Dr. Pavitra ma'am and Dr. Ravish sir, you can ask your questions now.
Yeah. Anupama, do you listen to me?
Yes, sir. Please.
Okay. One question is, who helped you for doing this study, madam? Or you alone did?
Sir, with interns, we all did, sir. Actually, I collected this report from the PHC center, and with the help of the ANMs and ASHA workers, I searched their home and I went and took their help also.
No, because it's very difficult to track 160 plus mothers in 2 months of time and
Yes,
tell you
sir.
that. And also the results what you have shown with regards to the knowledge of those mothers. I think the data has not been collected properly, because in the beginning you show that only some 4% of mothers knew about the number of antenatal visits, and you are showing about 40-50% who knows about the warning signs and other things. That does not match actually. And yeah, please.
The multiple questions I'd also asked, the danger signs of pregnancy. There are like multiple the answers they have given. So I think the multiple answers, whatever they had answered, even a single answer is corresponds to the correct response.
Mhm. And then coming to conclusion also, because once the card is given to the mothers, it has to be explained at the level of the primary health center where it is given, not in the television and all those things. It cannot be explained there regarding the MCH card. Okay.
Yes, sir.
Okay. Thank you.
Dr. Anupama, what was the objective of the study?
Ma'am, to describe the socio-demographic details and to assess the knowledge of the mothers.
Okay, after
Regarding
assessing
this
the
MCH.
knowledge, what are the benefits of doing the study?
Ma'am, actually, the benefits to the study is like MCPC cards. As far as now, it has been a recording system. They have not been looking into it. So majority of them were lacking with the knowledge. So to improve their knowledge, to find it beneficiaries for the next immunization promptly, and also to improve the nutritional status of the baby, or to help out the growth of the baby, where it lies and all. It's been just a recording system. So to help them out, it has been one of the major benefits.
Okay, your objective was to promote MCPC card as a tool of knowledge, as a source
Yes,
of
ma'am.
knowledge. Huh?
Yes, ma'am.
Okay. Okay, fine. Thank you.
Thank you.
Since we're running out of time, we request the judges to restrict your questions to 2 minutes, questioning time for 2 minutes, and the presenters please take their time. The next presenter is catch ID 147, Dr. Raksha.
Yes, ma'am. Can you please my screen?
Okay. Yes.
Thank you.
I'm given you control, but we can share your screen.
Yeah. Yeah, thank you. Okay. Can I start now?
Yes.
Yes, ma'am. Your time starts now.
1 second. Good afternoon, everybody. Is
Yes,
my
ma'am. You're
screen
audible.
seen? Yeah.
Yes, ma'am. Screen is visible. Your time starts now.
Good afternoon, everybody. I'm presenting a study on estimation of pregnancy in urban field area of medical college. Introduction. Coronavirus disease first broke out in the month of December 2019 Wuhan at Wuhan, China and spread globally by the beginning of 2020.
1 minute. Can you put your
2020?
excuse me, ma'am?
Yes.
Ma'am, can you put your slideshow on full screen mode?
1 second, sorry.
Yeah, that's okay.
Is it fine? Yeah.
Yes, ma'am. Carry on.
Thank you. On March 11, 2020, the WHO declared COVID-19 outbreak a global pandemic. As the pandemic spread, countries on of different magnitude to contain the spread of the virus. Whenever there is a complete shutdown of health services, women suffer the most. Amidst the COVID-19 pandemic, the United Nations in the month of 2020 predicted a sharp rise in the global birth rates, with India topping the list. A phenomena lockdown imposed intimacy has been observed, especially in India, which has been in turn resulted in the rise of unplanned pregnancies and abortions. According to UNICEF report, 116 million babies COVID-19 pandemic, India anticipated to top the list with 20.1 million births in 9 months since pandemic declaration. With the COVID-19 containment measures, life-saving health services like childbirth, antenatal care are affected, putting millions of pregnant mothers and their babies at risk. Lack of contraceptive coverage and healthcare services during lockdown led to high chances of unplanned abortions and stillbirths among the eligible couple. Hence the study. The objective of my study to estimate the number of pregnancies during COVID-19 pandemic among eligible couple residing in the urban field practice area of Bangalore Medical College and Research Institute. Coming to materials and method, a cross-sectional study design was done in urban slum field practice area of Bangalore Medical College. Study residing in urban field practice area, study period October to November 2020. Sample size according to the Indian pregnancy rate of 20% using the formula n is equal to z square pq by d square. The sample size was calculated to be 125 eligible couples. Inclusion criteria: eligible couple residing in the study area, pregnant females with LMP after 1st April 2020, and the exclusion criteria: eligible couple who have undergone permanent sterilization method and pregnant female with LMP before 1st April 2020. Method: after obtaining approval from the Institutional Ethical Committee and Medical Officer of Health, Chickpet, Belur, study was 420 eligible couples over 3 sectors in the field practice area. By probability proportion to size, 22, 43, and 60 eligible couples were randomly selected from sector 1, 2, and 3 respectively. Data collection: the data was collected using a pre-tested, semi-structured, face-validated questionnaire by household interview method. The data was entered in MS Office Excel and analyzed using SPSS software 20.0 version. Coming to the results, out of 125 participants, 36 were pregnant. That is 28.8% eligible couples, with 25% in the first trimester, 42% in the second trimester, and 33% in the third trimester. Mean age of the participant being 27.71 plus or minus 5.90 years, compared to that of the spouse 33.68 plus or minus 5.89 years. The minimum age of the participant being 18 and maximum 40, and that of the spouse being 22 and maximum 48. Of the study participants based on the religion: 54.4% comprise Hindu, 34% and 7% Christians, among which 52.8% participants lived in the joint family and 47.2% in nuclear family. Coming to the status of present pregnancy, out of 36, 28 eligible couples had unplanned pregnancies, that is 78% compared to 22% of the planned pregnancies. 99.2% participants and 97.6% of the spouse were unemployed during the lockdown, compared to 21.6% participants and 98.4% spouses being employed before the lockdown. 54% participants were scared to visit hospitals for antenatal checkups, and 72.2% participants had fear of delivering during the lockdown. Now, 29.8% eligible couples had no access to contraceptions during the lockdown. There was no significant association between pregnant women and their religion or type of the family. This study shows there was an increase in pregnancy rate, 28.8% during the pandemic as compared to the Indian pregnancy rate of 20%, with majority of pregnancies being unplanned, that is 77.8%. Limitations, as the in a limited field setting, a bigger study involving multiple areas with larger population would have helped in generalizing the results of the study. Recommendation: unplanned pregnancies could have been addressed by creating awareness and educating the eligible couples and increasing the accessibility to contraceptives in health centers during the pandemic. Acknowledgements: my heartfelt thanks to Dean cum Director of BMCRI and Medical Officer UHTC and MOH Madam for giving me permission to conduct this study. I thank all the UPHC staff who helped me in the data collection. I extend my heartfelt thanks to all the study participants, and I also sincerely acknowledge all the faculty and postgraduates of the department for their support. These are my references. Thank you.
Thank you.
Good, madam. You have touched upon one sensitive issue.
Thank you, sir.
And what is your inference at the end of your study?
So I wanted to, my inference is there is a slight increase in the pregnancy rate in my study population, sir.
So,
But yeah.
So what happens?
Which means we have to make ready for the resources for the baby boom. This may be.
No, that's a different story.
Yes, sir.
First of all, pregnancy has increased. So
Yes, sir.
naturally, giving services to those pregnant women are of utmost importance.
Yes, sir.
But these BBMP nor the state government is ready to cater to the facilities.
Yes, sir.
Now at that situation, that is
Yes,
what
sir.
is more important.
Yes, sir.
Very difficult now.
Yes, sir. Yes,
Everything has been converted for the COVID pandemic.
Yes, sir. Yes, sir.
So providing facilities for them is one thing.
Yes.
That is most important you would have brought in.
Yes, sir.
Yeah, thank you.
Yes. Thank you, sir.
Dr. Raksha, you have conducted this study in your field practice area, and all the study population belong to the same strata, isn't it? Same socioeconomic classification.
Yes, almost my middle class, ma'am.
You can expand the study and stratify your study result with the socioeconomic status and see if there is any changes in number of pregnancies and socioeconomic status with this COVID lockdown situation.
Yes.
I'm just giving an idea for further
Yes,
study.
ma'am. Thank you for the input, ma'am. Yes, ma'am. Surely, ma'am.
Thank you.
Thank you, ma'am. Thank you, ma'am.
Thank you, Raksha. Dr.
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Would you like to
Yes, ma'am. Yes, ma'am.
Okay.
Ma'am, shall I share my PPT?
Yes, I'll share it with you.
Ma'am, is it visible, my PPT?
Yes.
Shall I start, ma'am? Ma'am, shall I start?
Yes, sir.
Good afternoon, sir. Good afternoon, madam. This is Dr. Ashok from Jawaharlal Nehru Medical College. The title of our study is Risk Status Assessment in Pregnant Women presenting for antenatal care in urban care center in Belgavi. So coming to introduction, maternal health care is a major issue and challenge in developing countries. Provision of antenatal services valuable in protecting health of pregnant women and ensuring successful outcome. Adequate antenatal care can predict and manage pregnancy complications. The main purpose of antenatal care is to identify high-risk cases from general population and provide appropriate skilled care. So the World Health Organization has devised a simple scoring system that can be used to assess the risk status of pregnancy. Coming to the objective, to assess the risk status of pregnant women presenting for antenatal care in an urban health facility in Belgavi. Coming to the methodology, study design, it was a cross-sectional study. Study area, it was done in the urban field practice area of Department of Community Medicine in Jawaharlal Nehru Medical College. The study participants were the pregnant women who presented for antenatal care in the year 2019 and 20. The sample size was 214 pregnant women. Coming to the study variables, it involved the socio-demographic variables and maternal characteristics like number of surviving children, time since last delivery, gestational age of index pregnancy at booking, and past medical history, place of last confinement, and preference for place of delivery. Hemoglobin estimation, random blood sugar, and urine routine was done for every participant. So the WHO scoring system was used. Under this, the maternal characteristics, the first one was the age, under which less than 19 years and more than 14 years was given 4 points, and 30 to 39 years age group was given 2 points, and those between 20 to 29 years was given 0 points. Based on the number of children, those with more than 10 children were given 4 points, and those who had children between 0 to 1 were given 2 points, and those who had 2 to 9 children were given 0 points. Based on medical history, those with previous complications and perinatal deaths were given 3 points, and those with a history of diabetes, heart disease, renal disease, and psychosis were given 5 points. And based on maternal education, those who were illiterate were given 1 point, and those who were literate were given 0 point. So the scoring system was done, and the scoring system placed the pregnant woman with aggregate points as those who scored between 0 to 2 were at low risk status, those who scored between 3 to 5 were at high risk, and those who scored more than 5 were at very high risk. Informed written consent was taken, ethical clearance was also obtained, the analysis was done, and chi-square test was used. Coming to the results, the first table here shows the demographic characteristics of the study participants. So when the age was seen, the majority of the study participants, that is 129 out of 214, were in the age group of 20 to 24 years, and around 55 participants were in the age group of 25 to 29 years. And when literacy status was taken, 109 participants out of the 214 were secondary educated, while 49 participants were primary educated. In occupation, majority of them, that is 202 out of 214 were housewife, and 38 were students. On religion, most of them were Hindus at 103, and 97 participants were Muslim. The table 2 here shows the maternal characteristics of the study participants. So the first one here is the time from the last delivery in months. So 104 participants out of the 214 had less than 12 months interval since the last delivery, and 54 participants had a gap of 13 to 24 months since the last delivery. So based on number of children, 177 participants out of 214 had between 0 to 1 child, while 44 participants had between 2 to 5 children. Based on the history of previous complications, 1 participant had gestational diabetes, while 3 participants had preeclampsia, 5 participants had preterm labor, and 1 participant had postterm, and 8 participants had history of IUGR. And when anemia was taken into account, 121 participants had anemia, while 93 participants had no anemia. So based on this, the risk status was scored, and Out of the 214 pregnant women, 133 were at low risk, while 47 participants were at high risk, and 34 participants were at very high risk. So when association was done between risk status of pregnant women and the time of registration for checkup, it was seen that 81 out of the total of 214 participants who were at risk, out of the 81, 16 registered in the first trimester, while 50 participants registered in the second trimester, and 15 participants registered in the third trimester. Also, it was seen that when the comparison was done between gestational age 12 or...
Time is up now.
Yeah, I'm just concluding. Okay. When just a comparison was done between gestational age 12 or less than 12 weeks and those between more than 12 weeks, it was independent of the literacy status as well as it was independent of the socio-economic status. So conclusion, this WHO tool can be used to improve the coverage and quality of MCH and family planning services based on measurement of individual and community risk. Women who are at higher risk can be referred to higher centers for further management, and the remaining pregnant women can be given care at primary health care level only. So the recommendations, we can train our paramedical staff at the ground level to use a risk approach as a tool to as a tool to identify high risk pregnancy. And the first visit, we can score the risk status and classify them and give appropriate care and continue to give them appropriate care.
Sir, we need to keep in mind of the time so that...
Thank you.
Dr. Ashok.
Yes, sir.
Basically, please, you should know all these things. First is your number of slides should not exceed 10. You have done 20 plus slides. So
yes, sir.
please take care from next time onwards, because that is also important.
Yes, sir. Yes, sir.
In a nutshell, you should give your inference of your study. Similarly, time is also excess.
Yes, sir.
See, if you do like this, invariably you won't get the marks. That is as simple. Whatever the study you have done is as simple as it is. Okay. I have only one question for you. Why, as a community medicine PG, you have done this study?
Sir, because if the ground level workers like the ASHA, ANMs and all who are at the ground level, they can assess their risk status at an earlier stage, so that we can provide them the mother's expert management, and we can refer them at an earlier stage, and we can reduce the morbidity and mortality.
Is this assessment scale given to them from the government?
No, sir, not yet, sir.
Then how can you impose to them? That's all. Thank you.
Yes, sir.
Thank you, Dr. Ashok. No questions.
Okay.
Thank you.
Okay. Thank you.
Dr. Suma, are you here? Ma'am, would you like to start, please?
Hello?
Yes, ma'am.
Hello?
Yeah.
Yeah. Are you able to hear me and see the slides?
Yes, ma'am.
Okay. I'm going to start.
Okay.
Okay. So, title of the study I'm going to present today is Profile of Patients with Acute Encephalitis Syndrome Attending a Tertiary Care Hospital in Bangalore. 1 second. Encephalitis is of major public health importance worldwide as it causes huge emotional and economic loss to many lives. This was evident in recent outbreaks in June at Bihar 2019 and also Nipah outbreak in 2018 in Kerala. Etiologies and the epidemiology of AES are constantly evolving. Better epidemiological understanding of this devastating disease is essential for prompt management and preventive care. Objective of the study: to describe the socio-demographic, clinical, etiological, laboratory, and neuroimaging finding profile of acute encephalitis syndrome case patients visiting NIMHANS in the year 2019. Methodology: our study was a descriptive study, hospital-based record review conducted at NIMHANS for duration of 3 months from January 1st, 2019 to 31st December 2019. Study subjects were records of all patients who attended NIMHANS neurology emergency services and or outpatient department with acute encephalitis syndrome, diagnosed either clinically or etiologically using WHO definition of AES during the study period. Study instruments: based on the standard neurological procedures, a clinical case proforma was developed and digitized for data collection. Analysis was done using Microsoft Excel 2016 for Windows. Mean and standard deviation for continuous variables and proportions for categorical variables were computed. Sampling framework: a total of AES medical records having selected ICD codes were 176. They were from physical records and electronic records. Physical records, there were 121 records, of which 57 were excluded owing to non-infectious neurological diagnosis. From electronic records, 18 were excluded because of subacute sclerosing panencephalitis diagnosis. So overall, 101 case records were included for the study. So figure 1 shows diagnosis profile of patients with acute encephalitis syndrome who visited NIMHANS in 2019. Only about 42.57% of the patients were detected with etiology, and 57.42% of patients were with unknown etiology of AES. Out of 42.57%, 22 were having HSV encephalitis, 6 were having Japanese encephalitis and chikungunya encephalitis each, 4 were having chikungunya, dengue cross-infection encephalitis, 3 were with rabies encephalitis, 1 with dengue, and 1 with varicella encephalitis. Geographical distribution of AES case patients visiting NIMHANS have shown that majority of the patients reported to NIMHANS from South India, mainly from Karnataka. Along with this, majority of the patients were referred or visited from eastern and northeastern states of India also. Overall level 11 states, we were having patients from 11 states. Social-demographic characteristics of AES patients attending NIMHANS in 2019. Mean age of patients was 30.02 years, and the majority of the patients were in age group of 17 to 59 years, males with marital status married. Waste workers comprised of about 46.53%, and 55.44% have completed primary level of education. Approximately 65% have reported from the rural areas. Seasonality: overall, all AES patients reported throughout the year, but the peaks observed during June month and November, December, January, and February, which is usually post-monsoon period. Also, viral AES patients, the similar trends were observed during the post-monsoon, particularly November and December, whereas AES of unknown etiology, majority of the most peaks were observed during the first half of the calendar year. Then clinical features of AES patients attending NIMHANS in 2019. Fever was the most common finding, followed by seizures, altered sensorium. Classical triad of fevers, altered sensorium, and seizures were observed in 44.82% of AES patients of unknown etiology. Then neurological examination findings: abnormal plantar reflexes were seen in about 70.68% of AES patients with unknown etiology. Also, cranial nerve involvement is seen twice the time in viral etiology patients when compared to AES of unknown etiology patients. Figure shows findings of neuroimaging, hemogram, biochemical, and CSF investigations of AES patients attending NIMHANS. CT findings: mainly there were parenchymal changes. Hematologically, there was neutrophilia observed mainly in viral encephalitis, and increased ESR was found mainly in AES of unknown etiology. Anemia was present in about 30% of AES patients. Biochemically, hyperbilirubinemia was present mainly in AES of unknown etiology, whereas hyponatremia was present in viral etiology AS patients along with increased SGPT. CSF finding, CSF pleocytosis was seen in 51.16% of viral etiology patients, and increased CSF protein was seen again more in viral AS patients itself. Treatment characteristics of AS patients attending NIMHANS in 2019. Two categories of AS patients were given anti-epileptics mostly, followed by antibiotics, antivirals, but intravenous therapy fluids and NSAIDs were given more to AS of unknown etiology patients. Strengths and limitations of our study. The study provides a detailed socio-demographic, clinical and etiological profile of AS entity, which is rarely available in LMIC setting like India. Limitations include generalizability of the study, and majority of the study patients were adults in our study, while it is commonly observed among or affects children. Information on referral patterns and sequelae were not studied, and patients were not tested for scrub typhus. Hello? Hello? Okay. Recommendations. The testing of hypothesis, the following hypothesis is recommended, and syndromic approach to diagnosis, laboratory investigations and management could be planned. Increasing the battery of tests needs to be done to ascertain the etiology of AES patients and also to reduce that proportion. Further case series studies on severe cases of AES could be carried out.
Shall move to the question. Go to the judges now.
Yes. Yes, please.
Dr. Suma, what is the inference of this study?
It is mainly that we need to increase the battery of the test because as it is observed in various other studies also, etiology is not being determined mostly. And in our institute, there is chance of getting determined if we increase the battery of the test.
Okay.
Also,
have you compared your profile? You got demographic profile, right? Have you compared this profile with any of your other studies or any other centers' data like this?
Yes, I have compared with
Is it any different from anywhere?
Yes, cranial nerve involvement significantly we have found that usually in other studies cranial nerve involvement of third, fourth and sixth seen, whereas in our study seventh was also reported mainly. This is one peculiar observation and also difference. Yes, along with this, the socio-demographic features. Usually children are the commonly affected population in various studies, but in our it was adults, and we are thinking that it might be due to the presence of a tertiary care children's specialty hospital besides us, where there will be more references towards that hospital than a neurospecialty center for children particularly. Maybe this might have influenced. Also, waged workers were most commonly reported, whereas it is farmers usually in other studies.
Okay, thank you, doctor.
Dr. Suma.
Yes, sir.
Why you are sitting outside, I think, going to my building and presenting?
No, I am sitting in front of library, sir.
Okay. You would have sat inside somewhere. Okay. The question is, as a public health personnel, what you want to do with this study?
Okay, I would like to report the findings to the concerned officials or the departments, and then discuss about the shortcomings, and then come up with the better recommendations. Like for example,
Have you taken any history or details regarding the facilities available to know the shortcomings?
no, being a record review, I did do that, but there were shortcomings like there was no uniformity of documentation and all, which I observed in our study. So I thought to put this forward.
Okay, madam. Thank you.
Thank you, sir.
to the end of our presentation for today. The last participant. Thank you to all the participants and especially a great thanks to all the judges, Dr. Ravish sir and Dr. Pavitra ma'am for making time in their busy schedules to judge this event. And now we shall start the next session. Thank you.
Thank you all.
Thank you.
Thank you.
Thank you, sir. Thank you, ma'am.
Thank you, sir. Thank you.
Thank you.
Are we starting the second session?
Yes, ma'am, just a minute. Sorry for the delay. You all to the 32nd State Level Annual Conference of Karnataka Association of Community Health by Ramaya Medical College. The theme for this year is Public Health and Beyond. And with this, we shall begin with a session, oral paper presentation on non-communicable diseases. We feel very privileged to introduce our esteemed judges for today's session, Dr. Ravindra Reddy, Professor, Community Medicine, Vedhe Institute of Medical Sciences, Bangalore, and Dr. Rashmi Kundapur, Professor and Head, Shema Institute of Medical Sciences, Manipal. For the delay, was session got delayed. Now, so today's session will be moderated by Sejal and Divyanshi. We are 5th students at Ramaya Medical College. And we'll straightforward move to the instructions for today's session. So basically each presenter will be given 6 minutes to present and 2 minutes for their questionnaire with the judges. And after 5 minutes, we will give a reminder about the last. And after 6 minutes, we have to stop the screen sharing. So we request all the presenters to adhere to the given time. And we request you all to just go through these instructions. With the permission of judges, shall we start the session with the first presenter?
Yeah, please.
Okay. So first we have Dr. Ashwini Nair.
Hello. Hello.
Yeah,
Can you hear?
yes, ma'am, do you want us to present, share your?
Or do you want to share your screen yourself?
I'll share myself.
Okay, we'll make you the presenter. You may start now, ma'am, after sharing your screen.
Hello?
Yeah.
Can see?
No, ma'am.
Uh, Now can be seen?
It's taking time, ma'am. We'll let you. Yeah, we can see now.
Good afternoon, everyone. I'm postgraduate student from Pulmonary Medicine, Goa Medical College. I'll be presenting my topic. Cardiac troponin I is a marker for non-invasive ventilation as a treatment modality in acute exacerbation in COPD patient. I had help of my guide, Dr. Durga Lavande, my professor and HOD of our department. Coming to the introduction, chronic obstructive pulmonary disease is treatable, preventable disease. The fourth leading cause of death in the world is COPD, and by 2020 it's projected to be third leading cause of death. Cardiac regulatory proteins, cardiac troponin T and I, control the calcium-mediated interaction of actin and myosin using monoclonal antibody to epitopes of cardiac troponin I and cardiac troponin T. They are detected in the serum. COPD patients during an acute exacerbation with or without a history of copulmonal have an increased cardiac burden as stated in previous studies by Curie et al. Therefore, there may be a release of cardiac troponin I in these circumstances which has prognostic value. If it is, it could be an important predictor in such patients to point towards the severity of disease and need of aggressiveness in management. Our aim of the study was to evaluate cardiac troponin I and correlate it with the requirement of an IV in patients of COPD during exacerbation. Coming to materials and method, this study was conducted in the Department of Pulmonary Medicine, Goa Medical College, after approval by the Regional Ethics Committee. Study period was from November 2018 to February 2020. Study design was prospective cross-sectional study. The sample size was 109. The inclusion criteria was all patients of COPD admitted with acute exacerbation above the age of 40 years who were consenting for the study. Exclusion criteria was any marked renal failure, that is EGFR of less than 15 ml per minute, persistent hemodynamic instability which required inotropic or vasoactive support, pulmonary embolism, myocardial infarction within 1 month, or sepsis. In 109 patients diagnosed according to GOLD guideline 2019, earlier during the previous OPD visit in the previous 3 years, and now presenting an exacerbation with worsening of symptoms of cough, sputum production, breathlessness, and wheezing were included in the study. Each patient was given standard of care as per the GOLD guidelines, which included antibiotics, oxygen therapy, corticosteroids, inhaled bronchodilator, non-invasive ventilator, and other supportive treatment. Every patient was subjected to blood cardiac troponin I estimation using the immunofluorescence method during admission. And depending on the level of cardiac troponin I, they were divided into two groups. Those with raised troponin those with normal were included in group 2. Those requiring non-invasive ventilator were observed. A value of more than 0.016 was considered to be significant. The data was analyzed using the SPSS version 22, and tests were used by chi-square test in student T. And the results were, out of the 109 patients, 63, that is 57.7%, had raised troponin I, and 46, that is 42.3%, had normal troponin I. 55 patients required NIV of the 109 patients, out of which 44, that is 84.6% of the patients had raised troponin I, and 8, that is 15.4%, required NIV whose troponin I was not raised, which was statistically significant according with a p-value of less than 0.01. As we can see, those with raised troponin I were total 63, out of which 44 required, that is 84.6, required a non-invasive ventilator. The people who required non-invasive ventilator with normal troponin I were 8, that is 15.4%. This is the bar chart showing the requirement increased in those with blue, that is raised troponin I, and green was the normal troponin I, and yes signifies the use of ventilator, that is non-invasive one. Coming to the discussion, cardiac troponin I has been seen to be significantly raised in those patients with severe COPD exacerbation, as there is significant hypoxia, changes in the right chamber of the heart, higher chances of pulmonary artery hypertension, hypoxemia, and hypercapnia, thereby requiring NIV more frequently compared to those without these significant changes. Our limitation was that the study was only hospital-based, and the larger sample size could not be found out. A larger sample size is suggested to authenticate the findings of the study, as the sample size in the present study was smaller due to time constraint. Similar findings were also seen in previous studies by Noren et al., which showed about 78.9 and 38.7 patients which were requiring the ventilatory support, including non-invasive and invasive, among the raised troponin I compared to a normal group respectively. And in a study by Martin C. et al., the requirement of non-invasive ventilatory support occurring in nearly 38 of the patients, 38% of the patients with those with raised tropi. They also found that the patient had a 63% lower probability of requiring non-invasive ventilatory support if they had cardiac troponin I values lower probability. Coming to the conclusion, according to the observation made in our study, to see that raised troponin I can be used as a marker to identify those patients at the time of admission due to COPD exacerbation at a higher risk of complications, early initiation of vigorous therapy, ventilatory support, including a non-invasive mode of ventilator, is suggested in those with COPD patients in exacerbation who have raised troponin I, which can significantly reduce the hospital mortality. These are my references. Thank you.
Ashwini,
Yes,
I would want to have this. What type of study is yours? Study design.
Cross-sectional, my prospective study.
Prospective cross-sectional. Will you have cross-sectional is one time or a prospective study?
Sorry,
Will
ma'am.
you have a prospective and a cross-sectional? Prospective design is always a follow-up study. Okay.
Yes,
The
ma'am.
cross-sectional is one time. It's a picture. Then there is no prospective cross-sectional. Second
Yes,
thing is, what the conclusion what you have given, can a
Hello. I cannot hear you, ma'am.
Rashmi ma'am, you are not audible.
Hello. Hello.
Yeah, Ashwini, before
Yes.
Ashwini comes back,
Yes.
Dr. Ravindra here.
Yes, sir.
You all mentioned one is the study design. Okay, that's a question I also wanted to ask. Now you have kept 0.01 as the p value, no, for significant for your
Yes,
study.
sir.
What was the reason? What was the reason?
Sorry, sir.
You kept the p
Hello.
value 0.01, right?
Yes, sir.
Am I correct? What was the reason?
Sorry, sir. I cannot hear actually.
The p value to consider it as significant, you considered 0.01. Am I correct?
No, sir. 0.001.
0.001. So
Yes.
what is the reason?
Sorry, sir.
What is the reason? I'm not definitely wrong. So what was the reason to? Okay, let me ask them. Can you hear me?
Yes, sir. Yes, sir.
Can you hear? Yeah. So
Yes, sir.
you said your limitations of your study is one is hospital based, second is size, sample size.
Yes, sir. Hello. Hello, sir.
Hello, you mentioned the limitations of your study. One is it's hospital based study, and second is the size of the sample. Was
Yes,
the
sir.
size of the sample was not statistically calculated?
So because of actually the COVID pandemic started, so we were more posted in the other settings, so I couldn't collect for a longer period and more patients.
No, whether the sample size was calculated for your study or not, is what I mean.
Yes, sir.
So is it as per the calculated sample size required or different?
The problem was calculated sample size was around 300, sir.
Okay. So then second is, you said another limitation is it's a hospital based.
Yes, sir. Like
But
we had a single.
ventilator, can you do this in the community base because it is related to what? The
Yes, sir.
ventilator.
Yes, sir.
It is
Our department has a main major building is away from the our campus, our department, sir. Our department is separate from the hospital building. So major of the COPD patients get admitted initial stages when they present to the main building of Goa Medical College. So we are missing out many cases because of that reason. Yes.
Okay, Ashwini, I just want to ask you the whole part is when you have a case series, what you have done, how can you say what you have done with a statistical significance? What is that to do with the statistical significance? What association or what chi-square you have used for? Why you have used chi-square for this? Because it's a cases, right? Case series,
Yes.
right?
No,
Then
ma'am.
what is the chi-square used for?
Sorry, ma'am.
What is a chi-square used for when it is in a case series? When all are cases, how do you use it as a chi-square? What did you use chi-square for?
Actually, ma'am,
What was your objective?
objective was to correlate, ma'am, troponin I level and correlates requirement with NIV, ma'am.
Correlation and associations are two different things. How
Yes,
do
ma'am.
you correlate? What do you do for correlation for statistical significance?
Sorry, ma'am.
Chi-square is done for association, not for correlation.
Yes, ma'am.
Correlation, that's why your objective was something, you came with the result something else. Kindly go back, redo the analysis of your results. I think you should do correlation coefficient and association. Chi-square and t-test cannot be used in this. Rather, you can use it as a correlation coefficient. Just go back and redo the concept for this part of it. Thank you.
Thank you, ma'am.
Ashwini. So next up we have our next presenter, Dr. Kathi Himashweta.
Yes, I'm here. Am I audible?
Yes, you're audible.
Yes, I would like to share the video. Share my screen. Okay. Is the screen visible?
Yes, ma'am. Ma'am, you may start.
Okay. I think the slideshow. Okay. Good afternoon, sir, and good afternoon, ma'am. I'm here to present my study on title Levels of Physical Activity of Undergraduate Students Before and During Lockdown Amid COVID-19. My guide is my HOD, Sir Dr. Brigadier L.S. Vaz. Introduction to curb the spread of COVID-19, lockdown has been announced worldwide, which restricted movements of the population. This had both physical and psychological ill effects among people, and people were recommended to avoid social interactions and stay at home. Lockdown in Hyderabad was announced for almost 2 months, that is from March 22, 2020 to May 7, 2020. And after May 7th, there was a slowly unlock one. And so I took till May 7th, which was a complete lockdown in Hyderabad. With the announcement of social distancing measures and closure of gyms, etc., achieving the World Health Organization recommended physical activity levels, at least 150 minutes of moderate to vigorous physical activity or 75 minutes of intensive physical activity per week, or a combination of both in adults, became challenging. Need of the study is to explore the physical activity and sedentary behaviors among medical undergraduates during the COVID-19 lockdown, that is from March 22 to May 7, 2020. Objectives are to measure the levels of physical activity among undergraduates during the months of February to May, to measure levels of sedentary behaviors among undergraduates during February to May, and to compare the levels of physical activity and sedentary behaviors among undergraduate students before, that is, during February to March 2020, and during lockdown, during April May 2020. Materials and methods. Type of study, it is a cross-sectional study. Study tools. A web-based questionnaire was used to collect the information and is circulated to the students through Google Forms. The first section included consent form. The next section included questions regarding socio-demographic features of participants like gender, age, height, weight before lockdown and present weight, year of study, etc. And to assess the students' weekly time spent in physical activity, the International Physical Activity Questionnaire was used in the questionnaire. The IPAQ which I used, the questions were number of hours spent, number of hours in vigorous activity, um, number of hours spent in the vigorous activity per day, and a number of hours and minutes, and number of hours and minutes spent on moderate exercise per day, and number of days that they spent, and number of hours and minutes spent in walking, which I took consider that as a light activity, and questions on sedentary behaviors like watching TV, watching mobile phones, then playing video games on phones. So those are the questions. Study setting. All the undergraduate medical students pursuing MBBS course from first year to compulsory rotatory internship in Medicity Institute of Medical Sciences, Hyderabad. Inclusion criteria were students who are willing to participate, and exclusion who are not students who are not willing to participate in the study. Study period is from July 1st, 2020 to August 31st, 2020. Sampling method, it was a convenient sampling where the list of students from every year were taken, and from every year I took 70 students and I invited them to participate in the study. So coming to the gender-wise distribution of students, the male students, there were total number of male students were 102 and female students 217. And in our college, the female students were more compared to male students in general.
Dr. Gati, ma'am, you can switch off your video if there's some network issue.
Yeah, please switch off your video.
Dr. Gati, ma'am, you may switch off your video.
No, and power was off. I just connected through hotspot.
Okay, but if there is some
Hello?
internet issue, you can always switch off your video for better connection.
Okay, yeah, sure. Okay, thank you so much. Just
You may
power is
continue.
one of, yes. Okay, so these are the academic year-wise distribution of students, where the number of first year MBBS is 70, second year 68, third year 69, and there was a low response rate from final year MBBS. Only 42 students have responded, and interns is 70. Data was entered in MS Excel, and it was analyzed using SPSS software. So I used a pair t-test for my analysis, and the weight before lockdown and during lockdown, there was no significance. That means there's no difference in weight, and the other variables, there was a significant statistically significant was observed, like vigorous activity in minutes before lockdown and during lockdown, moderate activity in minutes before and during lockdown, walking before and during lockdown, sitting, phone usage, watching TV and playing video games, all were statistically significant. Conclusion: increase in both the activity and sedentary behavior compared to pre-COVID, which led to no net gain in weight. The increase in levels of physical activity is probably due to having availability of time, and increase in sedentary behavior can be explained due to the social restrictions. These are my references, and thank you, ma'am and sir.
Okay, this is Dr. Rashmi here. I just want to ask you certain things. One is uh, to get your questions, to compare between something. What type of study design normally we should use? Before and after, what is it? Type of study design. You have done before and after, right? There was something coming in, it was a before and after. Okay. Second question.
No, ma'am, I have no idea.
Yeah. Okay. In a cross section, can we have a compare? Or it is one time what is existing? You
Yes,
had
ma'am.
yeah, tell me.
I mean, at that time, what I did was I just asked the questions before lockdown and during lockdown. I compared.
Is the study design dependent on what you are doing or what it is for the participants?
What I am doing, ma'am. It depends on what I am doing.
No, sorry. It is for the participants.
Okay, ma'am.
That's how your study design is completely different, and comparison between two things cannot be done in a cross sectional. What type of cross sectional you can do, and how you have to do for that? Okay, now did you think that you had an hypothesis that they will reduce after lockdown or increase after lockdown?
I had a hypothesis that they will reduce the physical activity, ma'am, because of the restrictions.
Yeah, that is what I said. You started with an hypothesis. What type of studies do you start with an hypothesis?
And
it's an analytical.
Analytical, yes, ma'am.
That's what I wanted to say. So, the reason, what could be the limit? What was the limitation of the study? What your hypothesis didn't prove?
It proved that there was increase in physical activity as well as increase in sedentary behaviors, ma'am. So
Yeah. So, what is the confounder? For your hypothesis, what is the confounder? Okay, that's it from my side. It's time. Time is a confounder. You cannot be taken when the two different. You cannot compare apples with oranges. That's what happened. Somebody going to the school and somebody not going to the school cannot be compared. Okay, that's it from my side.
Okay.
Okay, Dr. Kati. Now you mentioned exclusion criteria as what? Those who are not willing to participate, right?
Yes, sir. Yes, sir.
Is that correct? Exclusion criteria?
Uh, no, sir. I had to ask. I mean, if they were. I mean, if they are not physically, I mean, if they have any back issues or not supposed to do any exercises, but I assume the I mean, there are students who are undergraduates. They could at least do some of the other exercises.
No. What I meant to say, exclusion criteria within those who included, whom are you going to exclude? It's not a separate opposite of inclusion is exclusion. Okay, that is one. So you
Yes, sir.
went for, you said convenient sampling, and then you have invited them for participation.
Yes, sir.
What was the response rate?
Out of, I mean, every batch had a different number of students, including the referred. So I took.
Have you invited everybody?
Yes, sir. I've invited everybody, but I had to make sure that I could take equal number of students from each batch for comparison.
That you're not mentioned that, because you told you have taken convenient sampling, number one. Number two, you said there was a low participation from third year or something like that, I say.
Fourth year, yes, sir.
Fourth year.
Yes,
Then, but how many you invited and how many were there in the fourth year? First point, how many you invited and how many responded? Unless you have the dropout rates from your invitation, because it's after all a Google form you have done online.
Yes, yes,
Not
sir.
that you have collected physically.
Yes, sir.
So that definitely is one of the very big limitation, because you said convenient sampling, then you say you invited whether you calculated a sample or not. That's number one. Number two, now the weight also you are seeing, the weight gain 4.5.
Yes, sir. Yes, sir.
Is there a limitation of that?
Yes, sir. I just asked them, right? I couldn't measure it. It is a self-administered questionnaire, so
So if they don't have a weighing machine and they not don't have the habit of measuring, they would have just said, I don't look like I gained weight or I don't look like I lost weight, rather than
Mhm.
really weighing. You could
Yes,
mention, right, whether that's
yes.
one of the. So what is the statistics used before to compare the p-values you mentioned? No? What are the statistics?
Students t-test, sir. Yes, sir. Student t-test.
So is it pair or unpaired?
Paired. Sorry, paired t-test, sir.
So pair t-test can you use every time is qualitative variables also? There are some qualitative variables also.
Uh, yes, sir.
So can you
I
use
have
pair t-test for qualitative?
so I've done only on uh, these variables are only exercise based. The time spent, not number of days. I just use the time spent on exercise or time spent on watching TV.
Okay, so all are quantitative.
Yes, sir.
All are quantitative. Okay, thank you.
Thank you, sir.
Thank you, ma'am. Moving on to our next presenter, Dr. Pooja RS.
Uh, I am not able. Okay. Okay. Stop sharing.
Dr. Pooja R. Sridhar.
Yes, ma'am. Can you hear me? Hello.
Yeah, you're audible. Can you be a little louder?
Yes, ma'am. Ma'am, can I get the share option to share my PPT?
Yes, ma'am.
Is my PPT visible, ma'am?
Yes, ma'am. You may
Yes.
start now.
Good afternoon, respected judges and all the delegates. I'm Pooja, postgraduate student from the Department of Community Health, St. John's Medical College, here to present on Is Screen Addiction a Problem Among Rural School-Going Adolescents? A cross-section study in 4 schools of Solur, Hubli, Ramanatha district, Karnataka. Adolescence is a unique phase that ranges between 10 to 19 years. Media, which includes social media, television, mobile phones, and computers, are a dominant force in their lives, and they have penetrated the rural areas as well. Since there is a screen, there can be an addiction. Screen addiction is a pathological compulsive use of screen based devices, and this has been linked to various associated mental health disorders. When we did a literature review, we found that there is a lack of published material regarding screen addiction among the rural adolescents. So we set out to do the study with the objectives of to estimate screen addiction among adolescents enrolled in 4 schools of Solur Hubli, Ramanagara district, Karnataka, and also to assess the factors associated with screen addiction among study participants. We did a cross-section study for a period of 2 months between September to October 2019 in these 4 schools, and the adolescents who were enrolled in these schools were part of our study. We did a universal sampling, and we excluded the students who did not comprehend the questionnaire and also who were absent on the day the researchers visited the school. For ethical clearance, we got the permissions from all the 4 headmasters of all the schools and also from the block education officers. We received an assent from the parents of the adolescents. We estimated a sample size of 335 from a previous study done in Mangalore, which had a screen addiction prevalence of 30%. We used a structured questionnaire which captured the data on socio-demographic details, physical activity, family, and academic stressors. To assess screen addiction, we used the Taos diagnostic criteria for internet addiction. This has a sensitivity of 90% and a specificity of 100%. This questionnaire is about a 7-item questionnaire which assesses regarding preoccupation, withdrawal, tolerance, or desire regarding usage of screen. A yes answer to question number 1 and 2 and any between 3 to 7 is considered to be diagnostic to have addiction. Then we screened for depression using the Patient Health Questionnaire 9. We imported this data into Excel sheet and we used the IBM software SPSS for analysis. For factors for association for screen addiction, we used the chi-square test and the logistic regression. P-value of less than 0.05 was considered to be significant. Let me draw your attention towards the results of our study. So the mean age of our study participants was found to be 15 to 14 years, and the minimum age was 12 and a maximum of 17 years. The table 1 shows the socio-demographic details. Majority of our participants were males, which was about 55%, and majority belonged to 53% were low, middle, and the lower class, according to BG Prasad. And when we asked about usage of any type of screen, which included computers, laptops, mobile phones, PlayStations, Xbox, 91% of our study participants, they said yes, that they did use any form of screen-based media. Even though there was a usage of 91%, we found that screen addiction was among 3.9% of our study participants. Then, all the factors which were associated on chi-square and Fisher's exact were put into the regression model. Let me draw your attention towards this table. We found that the males were 12 times more likely to have screen addiction as compared to females. Participants who felt that their parents fought frequently was 4 times more likely to have screen addiction, and students who did not participate in sports were 3 times more likely to have screen addiction as compared to the ones who did, and patients who were screened for depression using the PHQ were 5 times more likely to have screen addiction as compared to the ones who did not. And all these were statistically significant. Moving to the discussion of our study, so when we compared our study with a multi-centric systematic review and a Haryana-based cross-section study, we found that the mean age was somewhat similar. Screen addiction was different. Our study had a low of 4%, and the other studies showed varied from 16 to 30%. Screen addiction among males and depression associations were found between our study and also the Haryana study. Association with parent-child relationship was similar in our study and this multicentric systematic review. The reasons of this could be: one, ours is a rural setting. Though the screens have entered the lives of the people, maybe the addiction has not yet set in. Another, regarding the social desirability bias. Since this was a school-based study, children tend to answer the questions as how we require, and they tend to copy answers. The public health implication of this is we have to identify screen addiction and screen for depression as early as possible. This would reduce morbidity due to depression by addressing screen addiction. So in conclusion, the proportion of rural adolescents with screen addiction was found to be low in our studies. Males, children of parents who fought frequently at home, not participating in sports, and depression were found to be statistically significant with screen addiction. This can be prevented by recognizing screen addiction and depression among adolescent students by targeted intervention. Awareness regarding screen addiction among parents, teachers, and students has to be created so as to prevent this from becoming a public health problem. These are my references. Thank you.
Okay, Dr. Pooja, Dr. Ashmi here. Yeah, I was looking into, you went into the schools, right?
Ma'am?
Yeah. You went into the schools and asked them the questions?
Yes, no, ma'am, we had copies of the questionnaire, so we distributed among the students.
Okay, that was at one time?
Yes, ma'am.
Okay, whoever was absent on that day?
Was excluded from the study, ma'am.
Okay. Second issue is when you have already a high number of your frequency by itself is large number of males. How do you say males is as a reference, taking females as a reference, there is an association of screen addiction to the males?
Yes, ma'am, that could be a limitation, but the factors which were associated on chi-square and Fisher's, so we put that in the regression model, ma'am.
You're a postgraduate or an intern?
I'm a postgraduate student, ma'am.
Okay. Now tell me, how do you find an association? You said, what is the regression model? What will regression model do?
Ma'am, when in a regression model, when we put all the factors which are associated on a chi-square or Fisher's exact test, it will adjust for the other variables and give us the odds ratio, adjusted.
Yeah, but your sample, if your sample by itself is skewed, then will it adjust that?
No, ma'am.
If you look into your 95% confidence interval, it larged from 1.15 to 515.09. What does it say that? What
Yes,
does your
ma'am.
samples?
My sample size was 315, ma'am. So plus or minus 100 and minus of the
No,
range is.
I'm talking about your 95% confidence interval in your ORs. Look into your ORs. Your ORs confidence intervals ranged into 1.15 to 15.96.
Yes, ma'am.
Right? What does it say for you?
So if we apply that, the confidence interval is pretty large. So if we apply that to the population,
No, when you have it as cross, it is almost in 1 and it is at the 15. What does it say? Your whole of data is skipped. Your data is a not normal distribution.
non-parametric. Yes, ma'am.
So the basic is taking into one is into consideration says that it is almost no association at all. 215. So what does that say for you? 1.15 there, 1.46, everything is 1 point, and then it goes to 15 and 16 and 14.
Yes,
So no association at all, almost. Why does that happen? Why did you think that happened?
That is because, as you said, ma'am, that because our data was not normally distributed.
And the whole thing could not, like, if it was not normally distribution, can you do anything? Chi-square was a non-parametric, right?
Yes, ma'am.
Then what?
Sorry, ma'am.
Okay, go find out about that. I think that's the one reworking which you have to do. Otherwise, it's gone out quite well. But you should go and look into the reworking of those analysis, because your confidence interval, when it is so large, it talks about many things. Okay, thank you. That's all I've said.
Thank you, ma'am.
So that was a good point from Dr. Rashmi. So Dr. Pooja, that's just like we always look at the p-values. P-values, yes, they may tell something, but the range of the confidence intervals is also one of the other things. In fact, important thing many times are more important than the p-value itself in such comparison.
Yes, sir, I'll work on that.
Now you yourself told they might have copied and it was a school, so answering there may be bias. So what action you would have taken to minimize that?
So the action what we did while doing data collection was there was a supervisor in the hall, sir. So and also the teacher was there. So we tried our best so that the students don't copy. The other thing which we could have done is we could have sent the questionnaire at home, so they could have filled it at home and got it back.
So in the school, if you say, was there anonymous unlinked, or is it like they know the roll number, those things were written on their answer sheet?
Anonymous, sir. We didn't ask them to enter their names.
So that in methodology, if you explain what you are able to do to reduce these things, then you can say answers what they have given.
Yes, sir. Yes, sir.
That would have explained it for methodology. Okay, thank you very much.
Yeah, Pooja, you said in a Mangalore study, 30% screen. This one you found. What was it done? Whom was it done on?
It was among rural adolescents itself, ma'am.
Okay. Okay, that's what, because I just wanted to know about it. The author is we itself, so that's why I asked you that. Thank you.
Okay.
Yeah, next participant.
Can we move on to the next presenter?
Prachi Priya, no?
Hello.
Yeah, Dr. Prachi Priya.
Yeah. Am I audible?
Yeah, you're audible.
Yeah, I will share my screen.
Presentation. Okay, fine.
Is it visible?
No, it's not visible.
Now?
Not yet, ma'am.
Have you shared your present?
Oh, yeah. Is it visible now?
No, ma'am. Ma'am, you have to. made any changes, we can share your presentation.
Yeah, no, I have made the changes. Wait. I'll share.
Share it.
Now, yes.
Yes, it's visible now.
Yeah. So, this is Dr.
Go to slide.
Good afternoon, sir and ma'am. This is Dr. Prachi from SDM Medical College, Dharwad. And my topic for presentation is prevalence of risk factor for non-communicable disease. Okay. Hello.
Yeah, you can hear.
Yes, ma'am, you're audible.
Okay.
Go to the slide present.
Hello.
Yes, ma'am, we can hear you. You may continue.
Please continue.
But my slides are okay. So the topic is prevalence of risk factor for non-communicable disease and associated factors in the rule of. Yeah.
Can you maximize the size of your presentation? Can you put it on slideshow?
Slideshow play.
Is it fine now? Hello.
Yeah, that's fine now. You carry on.
But my slides are not visible to me.
Ma'am, we can see the first slide.
Okay. So the topic is prevalence of risk factor for non-communicable disease and associated factors in rural field practice area of SDM. It's the introduction. Non-communicable disease are non-transmissible directly from one person to other, and it consists of cardiovascular disease, diabetes, and stroke. It accounts for 68% of the global deaths, and India suffers the highest loss because of it. WHO estimates 60% of the all death, and the prevalence of non-communicable disease in the rural India is between 9 to 10%. So prevalence of risk factors for non-communicable disease and its associated factors in the rural population has gained public health importance. As we know, 2/3 of India's population live in rural areas. Hence, this cross-sectional study was conducted in rural area with the objective of prevalence for risk factor for non-communicable disease and its associated factor. Methodology: it is a cross-sectional study done in Yadwad for the duration of 1 month, and the study participants included were above 30 years, and those who were ill and did not wish to participate were excluded from the study. The calculated sample size using formula Z square PQ by D square is 157, and the sampling method used was systematic random sampling. Study tool used was community-based risk assessment score. Score less than 4 or equal to 4 means no risk, and the score 5 or more than 5, that means the risk is present. Result shows majority of participants, like 4.3% were above 50 years, and 56.1% were females, and around 98% of the participants were Hindus. 40.8% were illiterate, and 74% involved in the semi-skilled occupation, that is mainly farming. Study distribution on the type, family, and socio-economic status. Most of the 40% of the participants belong to nuclear family, and 33% belong to the joint family. While socio-economic status, most of the participants belong to class 3 and class 4 and class 5 socio-economic status. When community-based risk assessment score of less than 4 and more than 5 was compared with the various variables like age, gender, education, occupation, socioeconomic status, family type, religion, smoke or smokeless tobacco use, alcohol, and physical activity and family history, it was found to be statistically significant when compared with the smoke or smokeless tobacco product, alcohol, physical activity, and the family history with a p-value less than 0.01. In the discussion, I've compared my study with the studies done in UP, North Karnataka, and Mysore. The mean age of the study participants in my study is 47.96 years, while in UP and North Karnataka it is 37 and 38, while in Mysore it is 56 years. 90% of the population in the all study belong to the Hindu religion. And the tobacco use was 44.6% in the present study, while it was 35% in UP and 32% in Mysore. The use of alcohol in my study is 5.8%, while in UP and Mysore it was around 16.9 and 20%. Waist circumference in females and male, most in all the studies it was found that females were more towards the obese side, and the prevalence of risk factor in my study 17%, while in the study done in North Karnataka it was higher in men than women, and in Mysore it was 30%. And the factors responsible for the risk of non-communicable disease in all the studies were tobacco, physical inactivity, alcohol, family history, or lesser education, retirement from the job, etc. So I would conclude from my study that prevalence of risk factor for non-communicable disease is 17% in the field practice area of SDM, and the factors responsible for were tobacco, alcohol, family history, and physical inactivity. I would recommend to create appropriate awareness about the risk factor associated with the non-communicable disease, and the physicians attending OPD can emphasize on the lifestyle modification and encourage people for physical activity and healthy life, and discourage smokeless tobacco or smoking and alcohol. These are my references. Thank you.
Okay, this is Dr. Rashmi here. Again, I want to ask you, what is that different you have done in your study? Why should you have to do this study? What is the need for this study? Already we know about this. What was the need for the study?
Because initially the urban population are more prone to the non-communicable disease because of the sedentary life. And as we know, we are moving towards the technologies and everything. So in rural part of India, they have also set up.
What is the already present prevalence in the present prevalence of hypertension in a rural Karnataka?
Ma'am, it is
NFH's data.
13. Yeah, it is 13%.
Yeah, it's already been given. Risk factors are also been given. No, that's what I'm asking. How did you add as a betterment for the science during your study?
I wanted to create the awareness in where is the field practice area of my college. That's why I conducted the study there. Awareness regarding how to prevent
That awareness creation, how has that helped, would have been in better rather than looking into the prevalence of risk factors. You would have done what would have happened after you created and followed them up and found out what has happened to them. How did their attitude changed and what did their pattern change? That could have given you as a better one than looking into the prevalence of risk factors because it's already known. Prevalence. What was the highest prevalent risk factor? And how was that associated with the disease?
Smoke was the highest prevalent thing.
How much was the prevalence?
Ma'am, smoking was around 20 to 30%.
What has been in which age group? How did you classify the age group?
Ma'am, I uptake age group above 30 years.
Is that, don't you have to stratify there? What type of this one to eat depending upon the stratification of age group? Because different age group have different smoking practices, tobacco use practices.
I should have done like younger people have different smoking pattern and like elder people who are above 50 years have a different pattern of smoking and using smokeless tobacco products. So I should have done that.
That's it from my side.
Okay, Dr. Prachitya. Now, you mentioned your objectives as prevalence, but when I see really on the slide, it was looking different. Can you go back there? So quickly I could.
So which slide?
Objective.
Yes, sir.
Can you read the objectives here?
To determine the prevalence of risk factor for non-communicable disease.
Then, second.
Second is to determine the association of risk factors. for non-communicable disease.
Association of risk factors with non-communicable. Where association? What you looked at?
Use of tobacco products, physical inactivity. If there is a family history of non-communicable disease, that is compared to the score with scoring this thing, community-based risk assessment score I have used, in
Did
which
you
if it is
really
less.
do that in your study? Your objectives and what you really analysis of? Are they matching actually?
Sir, I have done it using that score only.
Okay.
Yeah, but you cannot do what sir is saying is, can we use doing the determine the association in the study design what you have done? Can we do an analytical association, causation when you're doing a type of study design what you have? That is what sir is asking.
And you mentioned one is risk factors prevalence and then factors responsible. So what is the difference you're looking at there? If you see the conclusion, during the conclusion, if I see the risk factors, then is factors responsible.
Like these factors were more like they were significant. Tobacco, alcohol, family history, and physical inactivity.
No, we didn't see that. What was that association you really looked at actually? Have you really analyzed or just you're telling?
No, sir. I've used the scoring system and then I have analyzed.
Because Dr. Rashmi was telling, the stratification and then looking at the different strategies. So stratification also, like 30 years you told more than 50 years. So either you have taken the 30 to 50 or 50 and above. Why that was taken? Was there 30 to 40, 40 to 50, 50 to 60 or something
No,
like
sir,
that
it
was
was
taken?
not taken like that. It was taken like if tobacco they are using, not using, if they are alcoholic or non-alcoholic, like that I have compared with the scores.
Okay.
Thank you.
Thank you, ma'am. Next up, we have our last presenter, Dr. PS.
Share.
We'll make you the presenter. Just give us a second.
Sure.
Yes, ma'am. Please start.
Good afternoon, everyone. I'm Dr. Karishma, postgraduate from KIMS Bangalore. Present obesity and its associated factors among reproductive age women, a comparison study. Obesity is considered as a serious public health challenge of 21st century all over world.
One second,
Obesity
Karishma.
Yes,
One
ma'am.
second, Karishma.
Yes,
Yeah,
ma'am.
your study is obesity and it says 1 second because I think what has come as a paper for us, it looks different. Can I just give a second so that I can change your presentation?
Mentioned as mental wellness of adolescents.
Yes, yes. Just show me your first slide because we have to rewrite it. We'll give you more time for that because your what has come has been totally different. Give your title. Show us your title.
Obesity and its associated factors among reproductive age women, a comparison study.
Obesity and its.
So was there a change in your study submitted, paper submitted compared to?
No, sir, I've submitted the same. I've not sent anything else.
The moderators please note it so that her it should be very clear for her getting a certificate and not a different study name. Okay, I have done it in my this one. You can go ahead, but moderator, please note it.
Okay.
Okay, continue.
Obesity is considered as a serious public health challenge of 21st century all over the world. Obesity in women of reproductive age has greater epidemiological significance because of women's childbearing role. The pregnancy and lactation is potentially a critical stage for the development of obesity, making women prone to maternal and fetal complications in subsequent pregnancies and increases the risk of non-communicable diseases. The etiology of obesity is multifactorial and complex due to involvement of genetic, behavioral, environmental, physiological, social, and cultural factors, which results in imbalance of energy intake and output. A detailed literature search regarding obesity and its associated factors among reproductive age women revealed scarcity of studies comparing rural-urban parts in India, which could form the basis for obesity control program in future. In this background, the study was taken up. With objectives to assess the proportion of obesity among study subjects, to compare the weight pre-pregnancy and 1 year post-pregnancy, to find out the factors associated with obesity. The study was undertaken by involving government referral hospitals, one each from urban and rural, after the approval by Institutional Ethical Committee. A total of 200 women, 100 each for urban and rural referral hospitals, completed 1 year of post-delivery and visited the hospital for immunization of their child, were enrolled in the study. Information regarding socio-demographic characteristics, dietary habits, practice of physical exercise, obstetric antecedents, and breastfeeding practices were collected using a pre-tested semi-structured questionnaire by interview method. Medical records were assessed to find out the pregnancy weight. Anthropometric measurements were measured to calculate BMI according to proposed Asia-Pacific guidelines. Results: Table 1, socio-demographic profile of study subjects. In both rural and urban settings, most of the study subjects were less than 30 years, educated up to 10th class, not working, Hindu by religion, belonged to nuclear families, and 30% had family history of obesity. Graph 1, distribution of study subjects according to proportion of obesity. In the rural setting, proportion of overweight and obesity was found to be 46%, whereas in the urban setting it was 57%. Table 2, comparison of weight pre-pregnancy and 1 year post-pregnancy. There was a statistically significant weight gain 1 year post-pregnancy in both settings compared to weight pre-pregnancy. Table 3, association between dietary practices and obesity. In both urban and rural settings, obesity was found to be more among study subjects who had junk food more than 3 times a week and consumed water less than 2 liters per day. Also in the rural setting, obesity was found to be more in study subjects who had a mixed diet. Table 4, association between physical exercise practice and obesity. In both the settings, obesity was found to be more among study subjects who had physical exercise practice less than 5 hours per week. Table 5, association between obstetric antecedent and obesity. In both the settings, obesity was found to be more among study subjects who underwent cesarean mode of delivery and who discontinued to breastfeed up to 1 year. In the urban setting, obesity was found to be more among study subjects whose age at first pregnancy was more than 30 years. I would like to conclude that the proportion of obesity was found to be 46% and 57% in rural and urban settings respectively. There was statistically significant increase in weight 1 year post-pregnancy compared to pre-pregnancy. In both the settings, obesity was more among study subjects who consumed junk food more than 3 times per week, water consumption is less than 2 liters per day, physical exercise practice less than 5 hours per week, who had cesarean mode of delivery, and those who did not continue to breastfeed. In addition, in rural setting, obesity was more among study subjects who had a mixed diet, whereas in urban setting, obesity was more among study subjects whose age at first pregnancy was more than 30 years. Recommend to incorporate components of obesity in health education during ANC and PNC visits to prevent excessive gestational weight gain and gestational weight retention. Further studies are needed in large samples to confirm study results, which will be useful for planning appropriate obesity control strategies. These are my references. Thank you.
Thank you, Karishma. Can you just show me your objectives, please?
Yes, ma'am.
Okay. Why have you again in none of your objectives it was between urban and rural, but why did your whole thing start later as when urban and rural? Your objectives never mention anything about urban and rural, whereas your whole part of your study was talking about urban and rural.
Yes, ma'am. I should have mentioned that in the objectives, ma'am. That I'm
And then
comparing
second
the
part is what are the factors associated with obesity? But looking into that, okay, what could be the bias when you see the factors after post-pregnancy 1 year? Just at 1 year, what could be the bias you can find to find an association factors? When do you think the normal weight comes back to a person after the pregnancy?
Ma'am, according to literature, it should be the minimum time to come back is 3 months. And ideally, women should get back to their pre-pregnancy weight by 1 year, ma'am. That's why we considered women coming for immunization after 1 year post-pregnancy.
Okay. As far as I know, I don't know. Can I get the this one references where you said that literature? Because as far as I know, it should be 2 years. So that's the reason when I said post pregnancy 1 year.
Gotten it from American Society of Obstetrics, ma'am. Mentioned in the article, ma'am.
Okay. Okay, just look into once again according to that because it should be as far as I know 2 years. And now when you've calculated the odds ratio for the whole part between urban, rural, between this, don't you think your sample is getting all over stratified and making it all unnecessary results coming out of it? Because your objectives are something for which you calculated your sample size and then you stratified multiple times into multiple categories and did the odds ratio. So look back into your statistical analysis once again before you go for any of the further things. That's all from my side. Thank you.
Okay, thank you. Pushpa, right? Karishma. Dr. Karishma, you mentioned before and after. This is a before and after study, basically, right?
Yes, sir.
And one of the thing was the weight and height for your BMI calculation before pregnancy was taken from the records, if I'm right.
Yes, sir. Pre-pregnancy weight was taken from the records, sir. From the mother's.
What was the limitation? What was the limitation of how come 200 people you add the records first point, and which point of time is before pregnancy the weight was recorded or available for you to take?
So we considered study subjects who had the pre-pregnancy, like first time they come to the hospital for diagnosis of pregnancy, they get the MCH card and the weight is written, sir. Those mothers who did not have antenatal records with pre-pregnancy weight were not considered in the study, sir. It was done in a stretch of 4 months, sir. So we took time.
Just at the first visit for antenatal, or how many days before they become pregnant? How do you know? Because my weight is recorded now, and then after 1 year I become pregnant.
So we have considered 2 months, sir.
No,
because it is said,
how it was available for you in your records? That's what I mean.
sir, because in these referral hospitals, as soon as UPT is turned positive, weight and height is looked at, sir, and all along with all other investigations, sir, antenatal.
So do you mean to say the pre-pregnancy is actually the weight during the first trimester of pregnancy?
Sir, it is said that the weight doesn't increase, according to literature, doesn't increase in the first 2 months, sir.
No, that's what. So am I correct in my this one that it was not a really pre-pregnancy weight? It was first trimester pregnancy weight. Am I correct?
Yes, sir, it was taken in first trimester, but the weight generally doesn't increase in the first 2 months, sir. There will be only a few.
But you have to be very clear whether it was before pregnancy
Yes.
or early part of pregnancy to later 1 year.
Early
after,
part, sir.
Early,
Yes.
1 year after the delivery you are looking.
Yes,
Now,
sir.
you said
That was the limitation, sir.
Some of the factors, related like junk food, less water, physical exercise. Unless you also have these factors before pregnancy, what they were doing, how can you really look at association of these things? Before and after, when you're looking at before what they were doing, after what they were doing, then you will be able to compare it. So then it becomes a cross-sectional. It's not a cross-sectional basically. When you say, those who are looking junk food and these things, unless what was their food habits before, what was their food habits later on? And then if you see the obesity, your obesity, what proportion of population had obesity, and your recommendations, are the recommendations matching with your results?
Also looked at KP and all that, sir. So I've presented only this component in this presentation, sir.
What is that?
We have also looked at the knowledge, attitude, practice, and all that, sir. So we have presented only this component in this paper, sir.
That's okay. Then you have to have the recommendation only for that component what you are presenting. You may have a much bigger results for the conference would have presented a part of that. Your conclusion and the recommendation will be for this part only, not what all you are looked at. Am I right?
Yes.
Okay. Thank you very much. All the best.
Okay, sir. Thank you, sir. Thank you, ma'am.
Thank you.
Now we have come to the end of this session. We would like to thank all the speakers for their wonderful presentations. And we request the judges to give some concluding remarks.
Yeah, Dr.
Yeah, I would just want to put it across for all of you. Quite good studies. All of you have taken an effort to do about it. Genuinity. But always, when you're having a research hypothesis, when research question, remember the finer criteria, the FINER, the finer criteria, and in your and in your objectives, be smart. 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 That's very much necessary because we in between have lost the finer criteria and the smart objectives. That's why the results probably we will not be getting what we are expecting. That's it from my side. Thank you. Thank you all. Ravindra sir.
Yeah, I thank the organizers for a wonderful arrangement with the limitation of the time and the COVID. They're able to efficiently. Then I am seeing only the presenters and we three here. I think 5 presenters are there and 2 coordinators and Rashmi and myself. 8 people, I think, total here. That's okay. Still, it was a quality time what we had, and the organization was really good. With the limitation of the internet and other things, things have not well. I congratulate the organizers, and most of you have done well. So all of you have done good, and then there is a lot of scope to improve. Also, I'm sure you will take forward whatever the feedback given. Dr. Rashmi has given a lot of inputs. Today she has given less inputs. Otherwise, it was in a conference on the stage. She would have really taken you task. He is a very good taskmaster as a guide. I myself have seen that. So wonderful inputs also have come up. I'm sure you will take back all these things and improve on your papers. See that next time you will do better. Thank you. All the best.
Thank you, judges, for insightful remarks. Now, request all the presenters to switch on their camera, please. We'll take a group picture.
All are not there in the group.
And Dr. Rashmi. Request all of them just for a few seconds only. Thank you, ma'am. Thank you, sir. Thank you, presenters. Thank you, sir. Once again. Yes, ma'am. We can't hear you. Ma'am, are you on mute?
Yeah, moderators just inform. I've already sent the mail for evaluation and also send it to Lalita madam. Just for your confirmation, just report it back to the scientific committee. Okay.
Yes, ma'am.
Thank you. Thank you. Thank you.
Bye, Doctor.
Bye, sir. Bye, sir. We'll meet soon. Bye.
Is the coordinator still there?
Yes, ma'am.